Increasing our education in increasing our education in critical care obstetrics is one of the ways that we can address these issues in maternal morbidity and mortality. Our first speaker needs no introduction. It will be Dr. Elizabeth Springer. Dr. Springer is a professor at the University of North Carolina and is an expert in global health. Again, we are so thankful you are here with us today, and we appreciate the fact that you have taken time out of your schedule to join us for our lectures. We will be back around 10 o'clock, I believe, our time, which is about 5 o'clock, I think, your time, to do 3 o'clock your time, I think, to do questions and answers. But just sit back, relax, and then write down those pearls and take home points. Have a great time during this session.
Okay, thank you so much, Professor Graves. So we just take it away from here. So the first lecture by, just a minute, by Professor Stringer will go on. Now, just a minute, just give me a minute, please. Here. Can we see my slides, please?
Okay. Yes.
Yes, we can.
Thank you.
Yes, I can.
Okay, thank you.
Yes, I can. You can't hear the speaker.
The speaker is muted.
Please, can you hear now? Hello?
I can hear you.
Yes, ma'am, we can hear you, ma'am.
Okay, but you can't hear the video.
No.
We could not hear the video.
Okay, just a minute, please. Somebody said I have to click on sound.
Maybe you should share the sound. After playing the video, if it's a pre-recorded one, you can share the sound.
Okay, just a minute. The sound, let me see. Elizabeth, let me just stop this. Elizabeth,
Yes.
can you help with this? No, I mean Elizabeth Docking-Link. Elizabeth Docking-Link.
Yes, ma, I'm sharing my screen already.
Okay, let me take mine down, please. So you can use yours. Okay, this is yours. Okay, yeah. Okay, so please go ahead and play, please. I seem to have
One should be able to describe normal physiological changes associated with pregnancy, discuss the impact of these changes. My name is Elizabeth Stringer, and over the next 25 minutes, I'll be talking about the physiologic changes in pregnancy as a segue into the meat of the lectures on critical care. I am a professor in maternal fetal health divisions at UNC Chapel Hill. I appreciate being able to talk to you all today. So by the end of my lecture, one should be able to describe normal physiologic changes associated with pregnancy, discuss the impact of these changes on maternal hemodynamics, and understand clinical application in common disease processes. Talking about critical care and obstetrics, and it is because unacceptable rates in the US and outside of the US. It is defined as death during pregnancy and up to a year postpartum. A third of maternal mortality cases occur during pregnancy. Another 1/3 from 1 week to 1 year after delivery. And then a third occur in some of the riskiest times around delivery and in the 1 week. This slide shows the absolute number of maternal deaths. We know that although the overall number is still relatively low compared to our population. Number of cases in the world, and as you all know, Nigeria has a large number of maternal mortality cases because of a large population. And in the US, these are often thought as near misses, and with appropriate care from deaths. I am really going to start off by talking about vascular pregnancy. This is the volume. This is the weeks of pregnancy. There's an increase by starting very early in pregnancy, as well as an increase in the plasma volume and a small increase in the blood cell volume. Unique problems encountered by pregnant women with cardiovascular disease are secondary to many of these physiologic changes in pregnancy. Cardiac output is defined.
Elizabeth.
Yes,
Yes, your slides are not showing, so you may need to unshare and then share again. You understand? Share, unshare and then share again and start again.
Ma, can I walk you through sharing your own slides?
Okay. So, but you have to unshare your own. You are still
Hello, Ma,
sharing.
can you hear me?
I can hear you.
Dr. Deshino, can you hear me?
I can hear you. Well, it seems you are not hearing me again.
Can I walk you through sharing your own slides?
Yes, you can.
Okay,
But you
when
need
you
to
share your...
wait, but you
when
need to unshare your screen.
No, when you share, it stops my own sharing automatically.
Okay.
Yes. When you share your slide, you just need to enable computer sound.
Okay. Computer sound. Okay. Just a minute.
Yes.
Let me try that then. Okay. Okay. Okay, so I'm just going to do that now. Just give me a minute. Why doesn't it show this? Okay, this is it.
Oh,
So the speaker.
Hit the arrow at the bottom of the page.
So can you hear now? Can you hear now?
Can't hear. We can't see anything. We can't hear.
I can hear and I can see. I can see and I can hear.
Oh, you can see and hear now.
Yeah, physiologic changes in pregnancy.
Okay, thank you.
My laptop is hanging. You should not message me, I beg.
Wow.
And I can do. We cannot take care of it, don't end that.
Everyone else needs to mute their device, please.
So I start where you can hear now, but they won't go back.
Yes. Elizabeth.
I can hear you, ma'am.
Yeah, but it seems people still can't hear.
I said there are three dots upwards. You can see you're currently sharing your slides. Then you see like
Yes.
three dots upwards. Just click on that dot. You see share computer sound or share sound.
Okay,
Click on
just
share
a
sound.
minute. Yeah, share sound. Okay.
Yes.
Okay.
Increase
So
in
is this
heart rate,
any better
increase
now?
in systemic
Yes, I
vascular
can hear it now. So you can start the
Yes.
video from the beginning.
Ah,
resistance. The decrease
no, can everybody
in
hear
systemic
now?
vascular resistance is really important. For
Yes, I'm hearing.
Okay.
Yes, I'm
I'm
hearing.
hearing now.
Okay, thank you. So we'll start. Apologies for that, please.
and I appreciate being able to talk to you all today. At the end of my lecture, one should be able to describe normal physiologic changes associated with pregnancy, discuss the impact of these changes on maternal hemodynamics, and understand the clinical application in common disease processes. Why are we even talking about critical care in obstetrics? And it is because of unacceptable rates of maternal mortality both in the US and outside of the US. Maternal mortality is defined as a death during pregnancy and up to a year postpartum. A third of maternal mortality cases occur during pregnancy. Another 1/3 occur from 1 week to 1 year after delivery. And then a third occur in some of the riskiest times around delivery and in the 1 week in the postpartum period. This slide shows the absolute number of maternal deaths. We know mortality cases are increasing in the US, although the overall number is still relatively low. The dark blue represents the highest number of maternal mortality cases in the world. And as you all know, Nigeria has a large number of maternal mortality cases because of the large population. And in the US, 1 to 3% of pregnant women will require critical care services, and these are often thought of as near misses, and with appropriate care are prevented from deaths. I am really going to start off by talking about cardiovascular changes in pregnancy and then move on to other changes in pregnancy. This figure shows, this is the volume on the left, and then this is the weeks of pregnancy. There's an increase by 30 to 50% in the total blood volume starting very early in pregnancy, as well as an increase in the plasma volume and a small increase in the blood cell volume. Unique problems encountered by pregnant women with cardiovascular disease are secondary to many of these physiologic changes in pregnancy. Cardiac output is defined as heart rate times the stroke volume, and there's an increase by about 50% in maternal cardiac output. There's an increase in the preload and a decrease in the afterload. Patients with limited cardiac output secondary to myocardial dysfunction, valvular lesions, or ischemic heart disease do not tolerate volume overload well during pregnancy. shows early changes in cardiac output, which is plasma, as well as plasma volume, stroke volume, which is here in the purple, and the blue represents cardiac output. And then there's a subsequent slide really shows the central hemodynamic changes associated with pregnancy by the numbers, and both CVP remain really unchanged in the non-pregnant versus pregnant state, whereas, as we've already said, there's a dramatic increase in the cardiac output, increase in heart rate, and a decrease in systemic vascular resistance. There's also a decrease in the pulmonary vascular resistance. The decreased systemic vascular resistance is really important for women with right to left shunts, and with regard to heart rate changes, we know that some pregnant women will have an elevation in their heart rate, low 100s, but if a pregnant woman has a consistently elevated heart rate greater than 115, that should alert the clinician to further workup. There are additional cardiovascular changes in labor. There's a marked cardiac output change, additional cardiac output increases in the primary, in latent phase of labor, as well as active labor. And cardiovascular changes can reach an additional increase by 50% by the late second stage. These volume shifts can fixed cardiac output, women with mitral valve stenosis, or whose cardiac output is dependent on an adequate preload, such as women with pulmonary hypertension. In addition, we have to think about the volume autotransfusion that occurs immediately in the postpartum period of 300 to 500 cc's. Not only are there significant cardiovascular changes that occur early on in pregnancy, but there are many respiratory changes as well. There are many lung function definitions that contribute, in being able to define these, it contributes to an understanding of the different changes in the respiratory system. And so on the left here are non-pregnant women, and then on the right are pregnant women. And what we really, I think, care about are, well, the total lung capacity is measured here in the blue on both sides, and you can see it kind of marginally, is not really changed in pregnancy. Although there is a significant difference in the tidal volume, which is measured here, as well as a decrease in the residual volume, which is measured here. And I'm going to talk a little bit more about that in the next few slides. So the respiratory changes that occur are due to both increases in progesterone, which acts as a trigger of the respiratory center and increases the sensitivity to carbon, to CO2. And there's also physiologic changes from the enlarging uterus. And this is a good graphic that shows that the increase in progesterone causes an increase in minute ventilation, which is really driven by tidal volume. The respiratory rate is not significantly changed during pregnancy, which causes an increase in the arterial PO2 and a decrease in the PCO2. The enlarging uterus causes an increase in the diaphragm, the elevation of the diaphragm, which is also counteracted by the GER abdomen. So the total lung capacity really remains unchanged, although there is an increase in the inspiratory capacity and then a subsequent decrease in the functional residual volume. Just to recap, there's an increase in minute ventilation, which causes a decrease in CO2. This is driven by a 40% increase in the tidal rate. This creates a respiratory alkalotic state. And then the kidneys actually compensate by excreting bicarb, and the mother also compensates by blowing off CO2, causing a subsequent increase in the pH. Here is just a cartoon diagram of respiratory alkalosis. This is the pregnant woman blowing off CO2, and then that shifts this equation to the left as the H is removed, and then the bicarb is excreted by the kidney. And this causes this, but in this case, and these are the arterial blood gas, or ABG, measurements in pregnancy. Lower than in non-pregnant women. The PCO2 is lower, the PO2 is higher, and then the bicarb is lower. And this becomes really relevant when we talk to our ICU colleagues or our pulmonary colleagues who don't understand that the ABG measurements in pregnancy are different than non-pregnant women, and so our targets are going to be different. And we know that adequate fetal oxygenation requires a maternal PaO2 of greater than 70, and that correlates with an oxygen saturation of 95%. And so compared to non-pregnant adults who we will tolerate an O2 sat of 90%, in pregnant women we really want it greater than 95%, and many of our colleagues outside of obstetrics don't know that. I also just wanted to tell an anecdote about a recent patient we had who had muscular dystrophy, and she looked well, like many pregnant women do, although she had complained of, increased shortness of breath in pregnancy, which how many of our pregnant patients don't complain of that? Well, we ended up getting her PCO2 36. And the pulmonologist at our institution were not worried about that, although we were very worried about it. And then when they got pulmonary function tests on this patient, they were approximating 30% of where she should be. And then she remained in the hospital. We had a multidisciplinary team meeting with pulmonology, anesthesiology, and we planned her delivery, and so that she could have a safe delivery. Now, just to recap, there is an increase in oxygen consumption. There's an increase in metabolic rate in pregnant women. Pregnant women can decompensate very quickly due to little pulmonary reserve. And I feel like I have been reiterating that, but it's so important to remember that there's little reserve. And then the oxygen saturation target is around 95%. Who are the pregnant women who we really need to be concerned about their pulmonary status? And this is just a short list, but it includes intubated pregnant women, because we want to work with our colleagues to make sure that the ABG is correct in the setting for pregnant women. Asthmatic pregnant women, they can retain CO2, but if you don't know what your target CO2 is, how are you going to know? Women with muscle weakness from Guillain-Barré or muscular dystrophy. And then, at least in the US, we see women with cystic fibrosis, and we really do care about their pulmonary function tests. There are additional hematologic changes in pregnancy that are important. As we've already stated, there's plasma volume increase that is greater than the increase in the red blood cell mass. This causes a physiologic drop in hemoglobin, hematocrit, and red blood cell count. There is no change in the mean corpuscular volume, or the MCV, and so we should be concerned when there is low MCV or high MCV. Platelet count can fall, but usually remains within normal limits, between 100 and 150. If we do see a pregnant woman with a platelet count less than 150, we do start to think, does she have gestational thrombocytopenia? Does she have ITP? We also want to be cognizant that she could also have preeclampsia. And then we all know that pregnancy causes a 2 to 3-fold increase in iron requirements and a 10 to 20-fold increase in folic acid. And so we want to be able to check that in pregnancy, because supplementation with iron and folic can have an impact on what occurs at delivery and what the hematocrit is at the time of delivery. We really want that to be as high as possible, especially in settings where there's limited blood, which is many places in the world. The risk of VTE is increased in pregnancy, and that is secondary to venous stasis, vessel wall injury, and hypercoagulability. 25% of maternal deaths in the U.S. are due to thromboembolic disease, and there's an increase in procoagulant factors, increase in fibrinogen, and then an increase in other factors. There's a decrease in the fibrinolytic activity at term, which allows stabilization of the clot at the placental site after delivery. And if we see pregnant women who in the antepartum or after delivery who have acute shortness of breath, we always will consider pulmonary embolism on the differential. I feel like I am seeing an increasing number of pregnant women who need anticoagulation in pregnancy. The number one driver of that, at least in our setting, is a history of a DVT or pregnant women who develop a DVT in pregnancy. I've also recently seen patients with atrial fibrillation or mechanical valves who are on anticoagulation, and it always makes delivery planning a little trickier with timing of delivery, as well as anesthesia. I needed to put a plug in for, against, I should say, therapeutic bed rest. And one of my colleagues, Dr. McCall, actually published this paper in the Green Journal in 2013, and it was titled Therapeutic Bed Rest in Pregnancy, Unethical and Unsupported by Data. And there are Cochrane systematic reviews that do not support bed rest for threatened abortion, hypertension, preeclampsia, preterm birth, twins, or fetal growth restriction. And it doesn't help those conditions, but also it can predispose, a pregnant woman to pulmonary embolism, which can kill her. And so we really do try to avoid bed rest. And I can't tell you the number of patients I see who always ask me, doctor, do I need to go on bed rest? Because they're hearing it in the communities. And I always caution against because of VTE. There are additional changes in renal anatomy and function, and there's an increase in the glomerular filtration rate by 50% for detoxification and metabolic byproducts. This can affect drug levels, especially anti-epileptics, for example. As the GFR rises, both the serum creatinine and urea concentrations decrease to mean values of 44 and 3.2. And we have to be very cognizant of what a normal creatinine is in pregnancy, and especially when it's associated with hypertension or diabetes. Progesterone impacts the dilation of ureters, the right greater than the left, and this can be associated, with also an increase in urinary stasis that can lead to pyelonephritis. There are changes in the gastrointestinal tract. Nausea and vomiting specifically affects 50 to 90% of pregnancies. It usually resolves around 20 weeks. And so, yes, there are women who have continued nausea and vomiting, but pregnant women who have new onset nausea and vomiting, in the third trimester of pregnancy, we need to think of other causes. Is it a pancreas? Is it HELLP syndrome? What is causing that? A small number of pregnant women will develop hyperemesis, and we always need to be thinking in the back of our mind in women who have substantial weight loss and hyperemesis that thiamine substitution is important to avoid Wernicke's encephalopathy. And then as pregnancy progresses, reflux can become more problematic, although reflux can also mimic right upper quadrant pain from a liver hematoma. And so we need to make sure that we're looking at blood pressures as well. Endocrine emergencies, and so I'm just really going to touch on some of the endocrine changes with regard to thyroid hormones. Serum free T4 and free T3 are not normally changed in pregnancy. There is a decrease in TSH in the first trimester due to thyrotropic effects of increased levels of HCG. Levels of TSH then increase in the second and third trimester. Iodine requirements are increased in pregnancy, and a goiter in pregnancy always needs to be investigated. Now I'm going to touch on a few just key differences with pregnant women and non-pregnant women, and I've covered some of these things already, but with regard to airway management, blood pressure management, and hemorrhage. Hypoxemia should always be considered as a cause of cardiac arrest in a pregnant woman. We know that oxygen reserves are lower in pregnant women and the metabolic demands are higher, and pregnant women can just decompensate so quickly. There are multiple causes of hypoxemia in pregnancy: pulmonary edema in our preeclamptics, or women with heart failure, amniotic fluid embolism, pneumonia. Now we have COVID to worry about, pulmonary embolism, an overdose of narcotics, high spinals, tuberculosis, and even COVID, as I've already mentioned. Intubation is not as straightforward in pregnancy due to the edema. Intubation should be performed by someone very experienced, and start with an ET tube of 6 to 7 millimeters, and really try to avoid more than 2 attempts, because prolonged intubation attempts can lead to serious morbidity and mortality in pregnant women. Supraglottic airway placement is the preferred rescue strategy when in a difficult airway. We are all familiar with the complications of preeclampsia, and we have to remember that our colleagues who are non-obstetricians don't necessarily know how to take care of preeclampsia or understand the pathophysiology of preeclampsia. HELP syndrome develops in 10 to 20% of cases of severe preeclampsia, and complications of HELP include abruption, DIC, and acute renal failure. As we, tend to expectantly manage women with preeclampsia in early gestational ages, 15% of women with severe preeclampsia will have significant morbidity, including things like retinal detachment or cerebrovascular bleed, which can be in the U.S. We are really focusing on increasing treatment of severe range blood pressures in pregnancy, and recognizing severe range blood pressures as emergencies. So a blood pressure greater than 160/110 for more than 15 minutes is considered an emergency, and we have developed protocols and for treating this. In pregnancy, there is a direct correlation between severe range blood pressures and pulmonary edema and stroke. And in a case series of 28 women with preeclampsia with severe features who had a stroke, all but one woman had severe systolic hypertension just before her hemorrhagic stroke, and half of these women died in the U.S., whereas a much lower number actually had a severe diastolic hypertension preceding her stroke. And I apologize that you cannot see that reference. Hemorrhage is really the last thing that I'm going to briefly touch on, and the uterine blood flow at term reaches 600 mils a minute. We as obstetricians, have a deep understanding of this, and that the average blood loss at delivery is between 500 to 1,000 cc's. I was recently giving a lecture to our surgeons at our institution, and not know how much blood flow goes to the uterus at the time at term, and why we don't do more hysterectomies. And because I was talking to them and saying that we really try to avoid a hysterectomy at all costs, just because of the large amounts of blood loss. Causes of hemorrhage are placental abruption, DIC, atony, accreta, and AFE. And we know that massive hemorrhage can occur in a matter of minutes, and therefore, protocols on how you're going to manage that, who you're going to call, and mobilize everyone to help treat massive hemorrhage. We use uterine artery embolization sometimes, but it's not effective in women who are acutely hemorrhaging, and so our first lines are more uterotonics, sutures, balloons, as opposed to uterine artery embolization. Final words, you all are the obstetric experts. Your knowledge of the physiologic changes in pregnancy will take you far in providing the best care for your sickest patients, and it will also enable better multidisciplinary care, because we've all been in this situation where the pulmonologist or the medicine doctor doesn't understand the unique issues to pregnancy, and that's why we all need to work together. I want to thank you and listening.
So thank you very much, everybody. I want to apologize for the low volume. Oops.
Good afternoon.
The low volume there, but we hope the other videos will be better. So let me just quickly share before we go on. So we have an idea of what is we have for the day. I hope you can hear me. Hello?
Yes, ma'am.
Yes,
ma'am.
Okay.
We're all hearing you.
Okay. So what we just had was the session by Dr. Springer. Then we're going to have a session with Dr. Fox, Professor Fox on placenta accreta. Then endocrine emergencies, management of hemorrhage. Then we have hypertension, cardiac disease, management of respiratory disease in pregnancy, and then sepsis. So just to let us have an idea, I'll put this in the chat box so that we can see it as well. So we'll quickly go on to the next video. We've lost some time while we're trying to walk through the sound there so that we don't lose any more time. Okay, so let me just share my slides here. Okay, so share.
My name is Erin Fox. I am an associate professor of maternal fetal medicine. Hello, my name is Erin Fox. I am an associate professor of maternal fetal medicine and our fellowship director at Baylor College of Medicine and Texas Children's Hospital Pavilion for Women in Houston, Texas. And it is a great honor to be here for the annual meeting virtually in Nigeria. Today, I will be discussing the diagnosis and management of the placenta accreta spectrum. Do not have any major disclosures other than the fact that I do have some grant funding looking at the molecular and vascular MRI of the placenta accreta spectrum. We will talk briefly about MRI in accreta. I'm also the primary investigator for the use of the resuscitative endovascular balloon catheter for occlusion of the aorta. I'm not a member of Jehovah's Witnesses, but I will be talking about some of their information in attempts to reduce blood loss and how to manage these cases when blood is in short supply. And I will also be briefly discussing uterine tamponade, the use of some novel hemostatic agents, including combat gauze, the intravascular balloon, and some matrices to help stop bleeding. The objectives for today's discussion are to allow you as viewers to implement a practical approach to screening and the intrapartum management of the placenta accreta spectrum based on your local resources, to appropriately map the treatment modality to the clinical scenario and appropriate patient selection as best possible, and to discuss some time-tested and novel methods that really go back to the basics of stopping bleeding. Why is this important? Again, it's important to remember that hemorrhage is a leading preventable cause of death, especially in areas like Africa. This is the case also in the United States. Hemorrhage is always amongst the top 3 to 5 causes of maternal mortality. And placenta accreta spectrum is a leading driver of maternal morbidity and mortality. Again, we're all familiar with the most common risk factors for the placenta accreta spectrum, of course, of which are the number of cesarean deliveries one has had and the presence of a placenta previa. And this data is over a decade old. We know, again, that even in women who do not have a placenta previa, as indicated on the column on the right, women still can have a placenta accreta, even without previa, and this number goes up as the number of C-sections goes up. Similarly, even women without a primary C-section in the first, people who may have multiple other deliveries, they may be grand multiparous, they may have had other surgeries, they also can have a placenta accreta spectrum even without prior cesarean delivery. So it's important to keep in mind that while those are the 2 most common risk factors, there may be other risk factors involved as well. Why is this important? We know from multiple studies that early detection and appropriate referral for management helps improve outcomes, especially for women, but also for neonates. So what are some other risk factors and what are the trends that we're seeing, especially in the United States, but also worldwide? Cesarean delivery remains one of the most difficult risk factors to manage. We cannot get rid of all cesarean deliveries. Clearly, an appropriate cesarean can be life-saving, both for mother and child. Therefore, we must make sure that when we're performing cesarean deliveries, they are truly indicated. In the United States, the first C allowing vaginal birth after C-section in the appropriate candidates. This has led to a reduction of about 4% in 2016 from a peak of well over 30% down to 31.9% of deliveries resulting in cesarean section. Now, this percentage, the incidence of cesarean delivery varies widely worldwide. In some countries, for example, Egypt, it can be over 80% in some centers. In much of South America, they have varying rates with private patients having a rate sometimes toppling over 70 to 80% cesarean delivery rate, whereas women who are managed by state resources tend to have a higher vaginal delivery rate. There's clearly something about avoiding the unnecessary cesarean delivery that helps reduce the risk of placenta accreta. There's been an increase in the number of conservative surgeries, however, that may also damage the integrity of the myometrium itself, and especially of the endometrial cavity and lining, such as septum revision, myomectomy, or endometrial ablation. It used to be, before these procedures were developed, that women with menorrhagia, for example, may need a hysterectomy for treatment if they failed medical management. Now we have far more conservative options, which allows a woman to retain her uterus, but this also provides her the opportunity to become pregnant. And whenever there is an injury to the endometrial lining, and particularly the myometrial integrity, this increases the risk for placenta accreta. So we don't have definitive data about how many numbers of cases of accreta are specifically due to these interventions, but those of us who work with patients who have placenta accreta and do their deliveries definitely see the increase. There was a very nice paper by Cynthia Ganfi-Bannerman in the Maternal Fetal Medicine Units Network that looked at the MFMU cesarean delivery registry. And in their conclusion, they noted that myomectomies, for example, did not appear to increase the rate of placenta accretus in that data. One argument about that particular study, however, is that they were looking in a cesarean database, that they were not powered adequately in order to detect small changes in the placenta accretus spectrum from these types of other surgeries, such as myomectomy. Had it been in a myomectomy database or in an accreta database, they may have seen a difference. Advanced maternal age is one of the oldest and longest recognized risk factors for placenta accreta spectrum. Back in the 1920s, when it was first described in the modern medical literature, grand multiparity and advanced maternal age were the two most common factors. The thought process is that the endometrial lining begins to thin as women age, and therefore this may be a risk. The mean age of first pregnancy in many countries is rising as women delay childbearing. Therefore, again, we have to take this into account. A lesser discussed but very well documented risk factor in the literature is the increased use of in vitro fertilization, especially with cryopreserved embryos, and this is beginning to trend. In vitro fertilization first was performed in the 1980s, and since then the use of in vitro fertilization has tripled as of 1996, and it's only becoming more common and more frequent as our science develops. However, this has been associated in multiple smaller studies, both in MFM literature and in reproductive endocrinology literature, to have anywhere between a 4 to 13-fold increased risk for the accreta spectrum. As I mentioned before, endometrial ablation, while again frequently used and frequently effective, it can lead to marked risk for a placenta accreta spectrum should a woman become pregnant after the ablation. Now, the reason we don't see that this as a frequent risk factor is our guidelines usually indicate that we should be performing permanent sterilization or provide adequate contraception for women who have an endometrial ablation because of these risks. On the right here, I have a picture of a patient who had a massive cervical implantation and a very extensive percreta that required pre-viable delivery because of massive bleeding. And again, while not common, it can lead to profound invasion and accreta spectrum. Same thing goes for radiation therapy and smoking. Thank goodness smoking is on the decline worldwide. Therefore, this may be less of a risk factor. Now, I've mentioned already that early identification is crucial. One of the first steps in identification is finding out the patient's history, as we've mentioned before, so that we can kind of think in our minds who might be at greatest risk. The next step is to perform ultrasound imaging that is thorough and complete of the placenta, not just the fetus. So this picture that I'm showing here is a wonderful example of how not just imaging, but appropriate imaging using the proper angles and techniques is very important. This is a sculpture called the Quantum Mermaid that illustrates a figure in the properties of light. Ultrasound works very similarly, only using sound waves instead of light waves. But you notice that the light does not reflect back to the observer's eyes on the sculpture very well until the viewer travels around the structure just by a few degrees. Once the angle is better, the light can reflect off of these structures. It bounces back to our eyes, and we can see very nicely that this looks like a mermaid, very much like the Hans Christian Andersen tale. So the angle of inclination of our ultrasound really matters. We must get a proper image in order to see the appropriate structures. And what I'm illustrating here in this image is the same patient in two different views, looking at a parasagittal image of an ultrasound right above the symphysis pubis. In the image on the left, we're using the transducer right against the patient's eye. See that the sound waves travel right past the bladder and placental interface. And so this bladder interface is shadowed out. Now, when we look at the placenta itself, a little bit in the middle of the screen, it's very easy to see on this image that it seems to be an anterior low placenta, very likely a placenta previa. There are multiple dark lacunar spaces, or these dark spaces that make the placenta appear moth-eaten or rat-eaten, which is already very concerning that there may be something going on. But notice in the picture on the right, what we've done here is we've tilted the patient into seat Trendelenburg. So the head is down, the feet are up, and we've rotated the probe so that it's almost parallel to the patient's thighs. And this allows the angle between the bladder and the uterus to be at a more, at a greater angle rather than 90 degrees, rather than perpendicular or parallel to the sound waves, perpendicular to the probe. It allows this interface much better. And for those of you who perform ultrasounds will likely agree that this placenta looks extremely concerning. We have a nicely filled bladder, which is very important, without having a full bladder with at least 200 cc's of urine filling the bladder. It can be very difficult to determine whether or not there's a bulge or just the bladder collapsed down around the placenta. This is a nice full bladder, and clearly as we follow this line of the bladder, there's a very unusual bulging. And we see these dark spaces going toward the bladder. Not only that, but the bladder line itself, which is usually a very bright white line, appears interrupted with some dark spaces that almost look like dots and dashes in between. And these are suggestive of vessels that are penetrating through that bladder wall between the placenta and the bladder. This particular case so far is already very concerning for percreta with bladder involvement. Another important view to obtain when looking at an ultrasound, especially in the second and third trimesters, is a transverse view. And this illustrates the same thing in the same patient I've shown previously. You can see here in the middle of the image where the arrows are pointing is the edge of the uterine interface with the underlying intra-abdominal contents and adipose tissue. And of course, on the left of the screen, you can see a kind of a dark shadow, which is indicative of the myometrium. And then toward the middle of the image, it just disappears. And then all you see is this lighter gray placenta that is bulging outward without myometrium surrounding it. Once again, deeper on the image, you see those rat-eaten or moth-eaten appearing lacunae. And again, this is very concerning. This is the left lateral parametrium that we're looking at. This is very concerning for some invasion through the wall of the uterus on the left side. And you can see how an appropriate and adequate image using ultrasound can be very informative. Once again, this is the same patient that we've seen in the last images, only this time we're using 3D color Doppler imaging. You can also do this in 2D imaging. Now, a couple of tips when looking with color Doppler, if you have that capability, is the first thing is that you want to make sure that your gain is not turned up too brightly or down too low, because you have to think that every patient's unique tissue characteristics are different, and therefore the Doppler may penetrate the tissues differently. One way to help standardize this Doppler gain is to first turn the gain all the way up so that there's very bright white aliasing within the vessels, and then turn it down just to the point at which that aliasing disappears. And that will help standardize the Doppler between patients or between machines if you're imaging the same patient using two different types of machines. Again, here you can see the full bladder. You do get a sense that there is bulging and an irregular shape of this placenta. But when we place the color Doppler on, you see that there's just marked vascularity behind this bladder line that goes all the way up to the bladder. And when we look at this image in a 3D rendered image, it just looks like a solid sheet of vessels. This is highly indicative and correlates very closely with risk for percreta, and maybe what can help identify just a focal area of deep invasion versus the difference between an accreta versus an increta or percreta. One way to help us standardize the imaging, as I've mentioned, is to get our minds first in the thought process of recognizing, preparing our minds to recognize that accreta when we start looking. And one of the ways to do this is by using a standardized checklist. This is a checklist here on the left that we developed at Baylor College of Medicine for our sonographers to use. First, just looking at risk factors, they check off yes or no. We can look at first trimester findings. Do we see a low implantation? Are there some irregular lacunae even on the first trimester scan? Is it offset? Or is the placental edge already over the os like a previa? And then findings that we can see in the second and third trimester. This also helps our radiologists if the patient has already had an ultrasound. There's a very nice internationally recognized checklist, pro forma, that I also like very much because it really focuses on first identifying some of the risk factors in history, ultrasound signs, and it forces the user to say yes, no, or unsure. It looks at cervical length, and it also allows for the user to document any color Doppler if available, and whether or not there's any suspicion for parametrial involvement when looking in those transverse sweeps. And then finally, it helps guide the sonologist to actually document for the surgical team, if they are different, what the likelihood of a normally invasive placenta or placenta accreta spectrum is, high, intermediate, or low, and the extent, focal or diffuse. The more descriptive language we can use when we're reporting out our ultrasound or imaging findings to the surgical team, the better idea that they will have when it comes to actually taking care of the patient if they are not actually reviewing the images with you, which is actually best practice. So what is the role of MRI? Again, this is somewhat controversial still. There are many experts who really rely upon MRI because it does provide a nice big picture of the entire abdomen and pelvis. For those gynecologic oncologists who are used to looking at MRI, it can be very helpful to define the topography of areas of involvement, but it may not be very cost effective. It is an expensive exam in comparison to ultrasound, and it may not be available everywhere. Therefore, most international and national guidelines do not mandate the use of MRI, but they, in cases where the placenta cannot be imaged adequately with ultrasound alone, which may be the case in women who are very obese, who have multiple fibroids, multiple pregnancies that can be very difficult to see low, even with transvaginal ultrasound or a posterior placenta, or if there's additional information needed that may change management if there is invasion through the side walls or posteriorly or into other organs. What is really important for both ultrasound and MRI is that it is critical that the sonologist or the radiologist reviewing the images has got experience looking at the placenta so they know what they're looking at, and the quality of images is very, very important. For MRI, the way that we perform them in Houston is that we ask our MRI techs to really take very small but rapid slices and to focus not only in on the uterus and placenta, but also to take a wider view of the abdomen, to do both, so that we can really obtain adequate imaging. The faster slice speeds are necessary simply because if slower images are taken, there can be a lot of motion artifact, both from fetal movement and from maternal movement. And once again, having a partially filled bladder is very important to help really identify the space between the bladder and the placenta. Here's an example of an MRI image. It is a different patient than the ones we've shown previously. And I apologize, I've borrowed this from a slide set that I used for Ethiopia, but you can see here again, a very nice full bladder. You can appreciate that we've got a low placenta, some bulging here into the bladder, and it's very difficult to see a clean line in between the bladder and the uterus, normally known as a fat plane. And it usually does come up as a slightly pale line. You can see that a little bit here on the image on the right, where there's a pale line between the bladder and the placenta. Now, in the image on the left, you can see that we've marked here a very wide intraplacental vessel. When we have a vessel, especially on this type of sequence, where it's very bright and very large, more than 6 millimeters, that correlates with placenta percreta. In the image on the right, we're looking at a sagittal view rather than the coronal view as on the left. You can again appreciate this is a complete previa. It's very difficult to even see the cervix. And here where there are asterisks, you see these very dark pinched bands. These are the T2 weighted dark bands that are highly suggestive of invasion. And the higher the volume of this banding, the higher the likelihood of deeper invasion. Another finding that we can see is the irregular border of the bladder. It should look more oval or egg-shaped, but instead there's kind of a beaking or a pointed appearance to the top of the bladder. And instead of being a nice, smooth, straight line, it's a little bumpy. And you just don't see all the way through this nice clear, that shows that there is a little bit of space between the bladder and the placenta. So I will argue that MRI, while expensive, should not be completely discounted because sometimes you can see better on MRI than you can on ultrasound. But similarly, it is critically important to know your local imaging resources, how well you're able to detect placenta accreta spectrum using both ultrasound and MRI. And I consider them somewhat complementary imaging modalities, analogous to how we think of using either a VQ scan or a CT for PE protocol to identify a pulmonary embolism. Each one has its own strengths and weaknesses. Sometimes you have to use both together, but if the index of suspicion is extraordinarily high, despite those images, it's important to keep that in mind. And reporting is also very crucial to our decision making. So let's take a turn toward management. Let's get back to basics. This is really important. Time is blood and time is life. Once a patient who has placenta accreta spectrum begins bleeding or contracting, that is where we start really getting behind, and resuscitation can be much more difficult. So again, early referral to the appropriate care setting is crucial, and making sure that you have things ready to go is also important. This is an example of the readiness programs that we have within our hospital. We have a very clear adult massive transfusion protocol that is shown here. The algorithm is shown here on the right. This allows any nurse or provider to know exactly who does what role within the team of people who respond to an active hemorrhage, what products will come from our blood bank. It has phone numbers listed for easy reporting, and just has the guidelines so that we don't miss any steps when we're responding to emergencies. We also have on hand uterotonic medications at the ready that we do occasionally use in our accreta cases as well. This is an example of the hemorrhage charts that we have on each of our labor and delivery units that have equipment such as additional IV tubing, some of the hemostatic gauze that we may use, balloons, for example, uterine tamponade balloons that are available here. And in each of our operating rooms, we have 2 hospitals where we work, and some of our ORs are in multiple floors, but on each floor we have a cart similar to this that has all of the equipment that one would need to complete a placenta accreta case, including that used by our interventional radiologists when they come, used by our urologists, such as cystoscopy and ureteral stents if necessary. Each item is listed very clearly on each shelf or each drawer, depending on how it's organized at which hospital. But even any circulating nurse, even if they're not as familiar with an accreta case, should be able to find the equipment necessary. This helps expedite getting the equipment that we need into the room if an emergency arises or if there's an unanticipated case. And we have found that when it comes to performing hysterectomies for uterine atony, for example, with no accreta, this has also helped trickle down the response times to those cases as well. So what do we do if we have an inability to transfuse, whether it is because of patient refusal of a blood transfusion, or our resources are just really low? We here have faced some blood shortages simply because of the COVID pandemic, for example. I have found that the Jehovah's Witness.org website has some very useful information to guide the discussion for those people who refuse blood transfusion. It is critical to individualize the treatment plan. For example, if there's a patient with a massive percreta that's invading into the sidewalls with a very high risk of bleeding, this is a patient in whom I will first ask what products we can use. If they refuse red blood cells, but we have fibrinogen containing products, for example, we may use those. Or this would be the patient in whom we would place a prophylactic aortic balloon catheter to occlude vessels very quickly if necessary in case of an emergency, and consider using a cell saver or normovolemic hemodilution. I think, again, one of the steps that we can use in all of our cases, and it helps also with cesarean deliveries, is to be mindful of using hemostatic surgical techniques whenever possible. Again, I cannot underscore the importance of a team approach enough, especially a multidisciplinary and experienced team. We and others have published the fact that using a multidisciplinary and very standardized approach really can improve outcomes. We are now entering the phase where we can use an overall standardized approach for the big cases, but we are also starting to finesse our approach to individualize care to the appropriate patients. For example, we used to have all of these consults with all of these experts before admission, but we do that now upon admission. And most of the counseling we do in our MFM clinic so that we don't have to delay patient care or spend a lot of time with our colleagues outside of the actual surgical suite. We've also now started using epidural anesthesia more unless a patient is unstable. Again, individualize who may need a interventional radiology consult immediately before the case begins versus for all cases, rather than doing a hysterectomy from a modified radical approach. In some cases, we can do a conservative surgical resection and allow the woman to retain her uterus should the clinical scenario permit. Now, this is really important, especially in countries and cultures where maintaining fertility is really important to women and to the culture. There are several varying management strategies, including leaving the placenta completely in situ, not touching it, and allowing the placenta to resorb or be expelled. This has been designed originally to reduce cervical morbidity, but has been used more frequently now to allow women future fertility. But it's important to understand that the various case reports and case series reporting this technique use adjunct modalities such as uterine artery ligation, balloon occlusion, and the median time to resolution can be anywhere between 6 to 9 months. So women who undergo this approach may carry placental bulk and have pressure, discomfort, very unusual dark vaginal spotting or bleeding for months. There is still a residual risk for bleeding and infection when placental tissue remains. And there have been certainly case reports of women going into DIC and needing an emergent hysterectomy, which may be up to as high as 20 to 58%, depending on the case series, which is reported. So this is not risk-free. And still, it's important to counsel patients that they may need an emergent delivery. And of course, if they live far away from your center, that can be technically very difficult because you're sending patients out without complete resolution of their disease process. And it's critical to make sure that their safety is maintained. They need very, very close follow-up. Most of the folks who report using this technique have women come at least every 2 weeks for several weeks, then monthly, and then have more frequent follow-up with a very clear and written documented safety plan and the ability to return to the hospital very quickly if needed. Cesarean hysterectomy, of course, is the more definitive approach where the uterus is removed along with the placenta. Again, this does require a strong surgical skill set, and there is a higher rate specifically of urinary tract morbidity. But again, it is the one way that we can definitively take care of the placenta that has invaded or involved other structures and ensure complete resolution within the shortest time frame. In between are uterine sparing surgical techniques to which I've alluded. The goal here is again to reduce surgical morbidity, secondarily to preserve fertility because it's not a guarantee. This usually involves focal myometrial resection of the involved area of the uterus and repair. Again, adjunct techniques such as balloon occlusion, uterine artery ligation may be necessary in order to stop bleeding. Some folks have reported use of a balloon, a tamponade balloon, or of compression sutures, for example. Again, this does have the benefit of immediate resolution if the entire affected area is resected, and it can be fertility sparing, but it is not possible in all cases. For example, whenever there is very deep cervical invasion or very wide lateral parametrial involvement, especially where the uterine arteries enter, it can be almost impossible to resect that region without taking out the entire uterus. So patient selection is probably key. Jose Palacios Caracamada from Argentina has reported the largest case series with very good success rates in his hands of this particular technique. But he has also been very clear in some of his most recent publications about the fact that it cannot be used for every patient, especially with very deep and very lateral involvement. So that begs the question, is there one better technique than another. And I will argue probably not necessarily better or worse. They are different with different risk profiles, but patient selection and very clear counseling is essential. And also the fact that even with the more conservative measures, patients need to be prepared that they may still require hysterectomy is important for honest and informative counseling. Again, this is an area for more research. Now, one of the other crucial updates that I'd like to let you all know about is that classically, the use of histopathology has been the gold standard for identifying whether or not somebody has a placenta accreta. However, that is often retrospective. It is after the fact. The placenta and all of the vessels that make delivery and surgery so difficult have collapsed. And so one of two things may happen. You may have a specimen where it doesn't look as bad as it really was in surgery. And so therefore the histopathology is read out as less than what it might have seemed in surgery. Or if the surgeons inadvertently disrupt the serosal tissue covering a placenta, it may look as though it were more invasive. And therefore, it's a little bit tricky to really identify whether or not what the surgical difficulty was just based on histopathology. Therefore, the International Society for the Placenta Accreta Spectrum, formerly the International Society for Abnormally Invasive Placenta, INFIGO, have come up with clinical classifications for placenta accreta spectrum. And this is just the surgeon or delivering physician describing what is seen clinically, and oftentimes also involves some histopathology. This also permits comparison of case difficulty and severity in those cases that are managed conservatively, where we will not have a histopathology specimen. And I encourage you all to look at these resources and use these classifications as you perform cases. Finally, there has been a US and with some European partners, a meeting to discuss standardization of pathology classification. And this is the 2020 system that was discussed in Philadelphia. And it is using a grading system that is a little bit analogous to the clinical grading system, only looking specifically at the depth of invasion that is seen on histopathology, and includes very clear definitions for the basal plate microfibers, oftentimes referred to as microscopic accreta. And it's really important that we all standardize this. I would really urge your pathologists to look at and use this system so that as we go forward with research, we can speak the same language. As I've mentioned, it's critical to think about a lot of different things when planning your approach to surgery, such as patient selection, including the anticipated severity and localization of pathology. What are your local and team resources? What is the woman's desire for future fertility or sterility? One may not be as heroic in saving the uterus if we have a woman who says, I don't want any more children. Has she already had bleeding or contractions? How far away does she live from the hospital? Can she return quickly if you're doing a conservative management? And is she reliable to follow up? Here's one of my favorite instruments to help control bleeding at the time of surgical management. It is our thermostat. Keeping a patient warm is crucial to reducing the risk for major maternal morbidity and mortality from the lethal triad. When bleeding begins, a patient can go into disseminated intravascular coagulopathy from either dilution from too much fluid, not enough blood product, or from consumption. When the patient then becomes cold, the vessels constrict, which leads to acidosis in the periphery. This acidosis then begins to start deranging the ability for the coagulation profile to work, as does the cold. And we can start getting derangements in both potassium and calcium levels, especially with a massive transfusion. And all of these together can lead to an escalating risk for death. This is what we do not want to see in our OR. This is a patient who had massive DIC. She did eventually survive, thank goodness. However, you can see that there is just blood everywhere. And this is a patient who needed over 90 units of transfusion. So what can help us when we are in surgery, other than the planning and making sure that we're using a hemostatic technique? Of course, placing the patient in lithotomy position so that we can see vaginal bleeding early and allow another surgeon between the legs, using adequate lighting such as a headlamp, self-retaining retaining retractor so that we have good exposure and freedom of our hands. And I cannot stress enough clear communication of the entire team, not only the surgeons together, but also surgeons with the nurses and surgeons with the anesthesiologists. I'd like to show you very quickly a video of the approach of a nearly bloodless cesarean technique that we have used. Here we're using a vertical skin incision because the patient is a little bit larger and to ensure we have adequate access. We've used Bovie cautery to enter the skin, and here we are pinching up the myometrium and creating a box of sutures to create an avascular space to close the sinuses of the uterus that usually bleed. We're entering the myometrium using electrocautery. You can also use a knife, but again, electrocautery is nice. You can place a linear stapler cutter underneath those sinuses, or just use 2 fingers to elevate that myometrium and seal those sinuses outside of that box. And then again, important to make sure there are no fetal parts in between, but you can see that the linear stapler cutter seals the edges, opens the hysterotomy with minimal bleeding. Alternatively, again, as I've mentioned, you can use 2 fingers, elevate the myometrium, and then as you cut, whether it's with electrocautery, with scissors, have a partner place clamps all the way across circumferentially around the hysterotomy, full thickness, that will also tampen out those sinuses. You can see here that the amniotomy is open. And we don't have an amniotomy, but the hysterotomy is open. The amnion is clear. There's sufficient space to deliver the baby if you just splay the clamps. You can see here also that we've incorporated the membranes into the clamps so that as we suture this up, we can incorporate that and tampen out any bleeding. It may be possible to use compression sutures if you have a small focal area of involvement or bleeding. Arterial ligation, of course, can reduce perfusion pressure to the uterus if you've got a focal area of involvement, even to the uteroovarian arteries or the IP ligaments. Because again, if you use a delayed absorbable suture, you will not completely cut off the blood supply. If the placenta is sufficiently high, you may be able to place a uterine tourniquet lower than the involved placenta, which buys you some time for ligation of the uterine arteries and reduces perfusion pressure. I would caution you from doing this with a very low bulky placenta because you don't want to press on that placenta. But you can use something like a vessel loop or a straight catheter and a vascular clamp to help ligate vesicure. And then also some other ways to just help stop bleeding if you get into it. Sometimes just a simple, very gentle gloved hand over a little area of bleeding, very gently, can help stop bleeding, as can the use of some combat gauze. These are gauze that must be removed from the abdomen here on the bottom that are impregnated either with chitin or with kaolin, which activates the coagulation cascade locally at the site of bleeding. It has been used by the military, both in the United States and Europe. Fibrin sealants that are cellulose-based, they do absorb, they have fibrin and thrombin powder on them. They are expensive, but they can be very useful. You place them on an area of bleeding. These can even sometimes stop bleeding on the liver or the aorta. Hold pressure for 3 minutes. This cellulose absorbs and it creates a patch over that bleeding area, very much like a clot would. This is just a brief view of multiple different types of balloons that can be used depending on your resources, including a condom on a catheter. And then it's important to consider aortic occlusion. If you just have massive bleeding, we can't do this anymore. On the left, this was actually from a textbook in 1922. But there is the potential now to use a balloon inside the aorta, not just in the femoral arteries, but in the aorta. When inflated, this will decrease all perfusion to the lower extremities and the uterus temporarily, usually no more than 30 minutes. These newer balloons may be inflated and deflated several times, but it does require an experienced interventional radiologist or trauma surgeon or vascular surgeon to help manage while the surgeons are managing the hysterectomy portion. And again, this is not permanent. It is intended to be temporary, just to give you enough time and control to be able to see the area of bleeding and control the bleeding. Aortic cross-clamping is always an option, as is manual pressure over the aorta. No matter how the aorta is occluded, it's important to remember to do so below the renal arteries to avoid disrupting blood flow to the kidneys, and to use sufficient pressure to actually stop the flow. If manual pressure is used, whether with the fingers, with the heel of the hand, or a fist, if blood can still be felt pulsating underneath, there is still blood supply going to the uterus. And so therefore, a pretty heavy pressure must be applied. It can be difficult to obtain, but it can be very effective just to temporize enough to gain control of the surgical field. So in conclusion, prevention of accreta is the first line of defense. Please avoid unnecessary procedures. Ensure C-sections are, when indicated, are truly indicated. And recognize that things like IVF, myomectomies, while important, do increase the risk. It's important to counsel women of this risk and to screen early. Refer to the most experienced center possible for your patients and refer early to give the patients time to understand what is going on and for the team to plan and prepare. Make sure that you're communicating emergency plans with your patients and the referring doctors in case somebody needs to go home but needs to be closer to the hospital near the time of delivery, because the most difficult cases are those in which the patient goes home, they live 3 hours away, and they start bleeding at home. And recognize that experience matters. Multidisciplinary management, especially with experienced team, does save lives. Use those hemostatic techniques always when approaching delivery. And again, make sure that you are really thoughtfully selecting patients for the appropriate management type, and always reserve hysterectomy as the backup when needed. And please, I'd encourage you to use a standardized screening approach locally, and communicate with one another locally, and use internationally accepted terminology for both clinical and pathologic grading and staging. If you love life, don't waste time. Again, that is what I tell our residents and fellows always, that time is blood and time is life. Time is what life is made of. Thank you very much for your attention, and I hope to get to see you for the question and answer period. If not, it is only because I am in the OR taking care of another woman with placenta.
Thank you very much, everybody. We thank Professor Graves for sharing from our vast experience with us. Placenta accreta is something that we obviously all need to pay attention to, especially with the increasing cesarean section rate that we all experiencing right now in a lot of our hospitals. We are now going to listen to another talk. This is by, this talk is on medical emergency among, just a minute, yeah. Medical emergencies. No, this is respectful. This is just a minute, please. By Professor Graves. Oh God. Give me 1 minute. Okay. Okay, so I'll just share my slides now so that we can look at that slide. I'll encourage us to please jot down our questions. They will be coming in from time to time to
and thank you for joining me for this lecture regarding managing.
Okay.
Good afternoon, and thank you for joining me for this lecture regarding managing acute endocrine emergencies in pregnancy. Today, we will be reviewing diabetic ketoacidosis and thyroid storm. I am Dr. Cornelia Graves, and I'm happy to be here with you again this afternoon. At the end of this discussion, the participant will be able to understand the impact of uncontrolled endocrine disease in pregnancy, recognize the signs of an endocrine emergency, and formulate a managed plan for emergency care. Before we go any further, I would like to reveal that I have no financial disclosures for this presentation. We will begin with diabetes and diabetic ketoacidosis. In the first trimester, there are changes in the pathophysiology of insulin utilization. Due to an increased incidence of estrogen, there is also increased insulin sensitivity. This increase in insulin sensitivity means that patients may be more likely to have hypoglycemia. Nausea and vomiting, as with hyperemesis, also can complicate patients with diabetes. There may be decreased peristalsis in patients with diabetes from diabetic gastroparesis that may also be exacerbated in the first trimester. As we discussed, due to the increase in estrogen, there's an increased incidence of insulin sensitivity, which means that some patients may present with hypoglycemia, requiring a lowering of their insulin dose from their preconception levels. In the second and third trimester, however, there is an increase in human placental lactogen, prolactin, and cortisol. This results in the patient being increasingly insulin resistant, and there's a reduced sensitivity to insulin action. This begins as early as 16 weeks and continues to rise. This insulin resistance continues to rise until 36 weeks of gestation. When we talk about diabetic ketoacidosis, we're really talking about a collection of severe and potentially life-threatening metabolic disturbances. Diabetic ketoacidosis has three components: elevated blood glucose, hyperglycemia resulting in an osmotic diuresis. This causes the loss of fluids and electrolytes, particularly potassium, as potassium is not only lost in the urine, but also due to the fact that insulin is no longer able to put it into the cell. There's intravascular fluid contraction. And even though the patient may have hyperkalemia on her labs, due to the changes in potassium metabolism, that she may still be potassium deplete. There's ketone production, which may result in a metabolic acidosis. Hopefully, the patient will be able to compensate with the respiratory alkalosis, hyperventilation, significant hyperventilation, also known as Kussmaul's respirations. And last but not least, there's uncontrolled lipolysis, resulting in severe hypertriglyceridemia. When we look at this diagram, the lack of insulin causes several things to happen on a cellular level. Insulin allows for the cleavage of glucose to pyruvate. When pyruvate is blocked because there is no insulin, the Krebs cycle cannot take place. When the Krebs cycle cannot take place, it then goes to anaerobic metabolism, resulting in the formation of acetyl-CoA and keto acids. In addition to that, insulin does not allow for free fatty acids to be broken down appropriately. They drive things to acetyl-CoA and free fatty acids. And again, insulin is needed, as you can see here in this diagram, to convert these to triglycerides. So you have continued circulation of these fatty acids back into coenzyme A, and then to keto acids. So it is really the fact that insulin cannot work on the cellular level, cannot put glucose in the cell on a cellular level that drives this process. Well, what are the risk factors for diabetic ketoacidosis? In type 1 diabetes, often it's the first presentation of pregnancy. Patients may present to your department with hyperglycemia and basically have never known that they had diabetes. Acute illness, such as flu or a GI virus, may cause DKA. Insulin omission, the patient says, oh, I was sick, so I just didn't take my insulin. She's not able to comply with therapy. Or eating disorders, especially in young people. The omission of insulin keeps one slim, And especially in some cultures, this is highly desired. So the patient decides that she is not going to take her insulin for that reason. However, and DKA can also occur in type 2 diabetes in pregnancy due to stress, due to ethnicity, such as African descent, due to some of the things that we do in pregnancy, especially tocolysis and steroids. DKA is seen in patients who use the insulin pump and not syringe injections due to pump failure, in patients who just don't control their glucoses outside of pregnancy, and of course, extremes of age, over 40, less than 18. Well, what are some of the precipitating factors of diabetic ketoacidosis? Acute illness in 10 to 20%, new onset diabetes, as we talked about, 5 to 39%, insulin omission, 33%, and infections, 20 to 28%. So your patient comes in, what are the signs and symptoms of diabetic ketoacidosis? Increased urination, polyuria, increased thirst, need to drink water, polydipsia, and weight loss. Next is fatigue, nausea and vomiting, and abdominal pain. I want to pay particular attention to the nausea and vomiting and abdominal pain. Often these are misdiagnosed as some type of GI virus. Always keep in mind to check glucose, as this is a common symptom. Then, as we talked about, the hyperventilation, the compensatory respiratory alkalosis of Kussmaul's respiration, smell, kind of a sweet smell coming from the breath, and mild impairment in cognition. pH may be decreased to less than 7.3, serum bicarb less than 14 and less than 15, and an anion gap greater than 14. As you recall, your anion gap is calculated by taking your positive ions minus your negative ones. Potassium is omitted because it's such a small part of the positive ions. So it's really your sodium minus your chloride and your CO2. Raised serum ketones and urine ketones, or lactic acidosis, and then a blood sugar greater than 250. However, in pregnancy, keep in mind that occasionally blood sugars are normal or only mildly elevated. So what is the management of diabetic ketoacidosis? First, you want to monitor the patient. Then you want to do IV fluid resuscitation. Remember, these patients have increased urination, so they have a 3 to 9 liter deficit. You want to replace their potassium. Keep in mind, if they're not peeing, they're not putting out potassium, so you need to make sure that you're giving them IV fluid resuscitation, IV insulin, and then identifying the underlying cause. And we review these as we go. First, when should your patient go to the ICU, or in some places where labor and delivery may be advanced enough for them to stay there? If their pH is less than 6.9, or they have inadequate respiratory effort, a loss of consciousness, and severe metabolic disturbances, a potassium less than 3 or greater than 6. If they're going to stay in your labor and delivery, they must have some type of cardiac monitoring, either through telemetry or direct ability to evaluate cardiac rhythm at the bedside through a monitor there. So the first thing we want to do when we monitor, we want to check our glucoses. We want to, after we get our patient on an insulin drip, we want to start checking them initially when they hit the door, and every 1 to 2 hours while they're on the drip. We want to check our electrolytes initially and every 2 to 3 hours. Every 4 hours, you need to check your anion gap, or if you have an arterial line in place, you can check your pH through blood gas. And you continue to check these patients until the volume is stable and IV fluids are at maintenance rates and there's a normal potassium. You want to monitor calcium initially and then every 12 to 24 hours unless it's abnormal. Make sure you correct your calcium for albumin, low albumin. And then, unless your medical record provides you with a flow chart, I always tell people that a flow chart is helpful to make sure that you're going in the right direction when taking care of these patients. You also want to obtain the following: an EKG and cardiac enzymes. Keep in mind that many patients will have a silent, what we call a silent myocardial infarction. And so therefore, especially in patients with long-standing type 1 diabetes who are poorly controlled, and that could be, she could be 29 or 30 years old and have long-standing diabetes, an EKG is necessary. Workup for sepsis and infection, cultures, chest x-ray, and urine analysis. And then another thing to consider is the pulmonary embolism, especially in the pregnant population. Well, let's talk about our IV fluids. The first thing we need to do is we need to give 1 to 2 liters of normal saline over 1 to 2 hours or longer, so that there's no more tachycardia or low blood pressure or hypertension, orthostatic changes, or low jugular venous pressure. Sometimes you may need to give, 2 liters in the first hour, especially if the patient is significantly hypotensive. Once you get the glucose to less than 250 milligrams per deciliter, you need to change to D5 half normal saline. Then you need to give them 200 to 500 cc's an hour over 12 hours to replace at least half of what you anticipate as their deficit. Then lower 100 to 150 into the deficit is restored and the patient is eating and drinking well. You say, Dr. Graves, guess what? I've done all that. My patient's still hypotensive. What do I need to consider? There's a syndrome called Smith syndrome. That's an autoimmune syndrome that's associated with type 1 diabetes, adrenal insufficiency, and thyroid disease. If the patient is hypotensive, consider cortico or adrenal insufficiency, send a stat plasma cortisol and ACTH, and then begin Solu-Cortef replacement at 100 milligrams every 8 hours. The thing with DKA is the mortality is quite high. For mothers, 5 to 8%. Hypokalemia being the most significant. And then from the other underlying things that cause diabetic ketoacidosis, including myocardial infarction, stroke, pulmonary edema, pulmonary embolism, pneumonia, and other infectious etiologies, sepsis. But the thing you need to remember is that fetal mortality is up to 50%. However, if the fetus does not look good or you cannot monitor the fetus, you should not worry about intervention, even if the fetus is term. Taking an unstable mother for an emergency delivery is not recommended. You should correct their diabetic ketoacidosis, which the abnormal monitor tracing, and return everything to homeostasis. Well, let's look at potassium. We talked about the potassium deficit. So there's probably a 3 to 5 milliequivalent per kilogram deficit. Ketoacidosis without insulin, there's no potassium going into the cell. So when a patient's insulin is blocked, the potassium is extracellular and not intracellular. So we want to replace our potassium initially with IV fluids and insulin, unless the patient's not making urine, or her potassium is greater than 5.5, or the EKG shows elevated T waves associated with hyperkalemia. And if we need to aggressively replace potassium, if we're going to do more than 20 milliequivalents per hour in a bag, then you need to cardiac monitor, and then greater than 60 per liter unicentral line. Most people use 10 milliequivalents per liter, we call K-runs. And so therefore, we were able to then put the potassium back in without specific equipment. However, hopefully your patient is on some type of cardiac monitoring if she's in DKA. This is your potassium replacement. That's what I said before. Greater than 5.5 milliequivalents per liter, nothing. If they're between 5.2 and 5.5, you can give 10 milliequivalents per hour, which you can put in your IV fluids. 4.0 4 to 5.2, 20 milliequivalents per hour, 3 to 4, 30 milliequivalents per hour, and less than 3, 40 milliequivalents per hour. Keep in mind, if you're going to put your potassium in your IV fluids, you need to account for that as well. Well, you said, Dr. Graves, you waited to talk about insulin. There's a reason for that. You may want to delay starting IV insulin for a few hours if their potassium is really low and their metabolic acidosis is not severe. This allows you to catch up with their potassium, drive some potassium in the cell, and hopefully make sure that you're not incite arrhythmias. All insulin drips are by Humulin R. Some places may have some type of computer that calculates. Otherwise, you can just titrate per protocol. You should give a bolus of 0.1 to 0.2 units per kilogram IV, or I just cheat and give 10 units. Some of it's going to stick to the plastic of the tubing. Then you need to give a drip at 0.1 to 0.2 units per kilogram per hour. And just so you'll know, you need to mix 50 units of regular insulin and 500 cc's of D5W, which will give you 1 unit per 10 cc's. So that then helps you to titrate on your pump without having to do fancy calculations. The aim is to correct their anion gap and to decrease their blood sugars about 80 to 100 milligrams per deciliter per hour. Most importantly, decrease their anion gap. Monitoring serum ketones is not useful, as most assays measure only acetone. Keep in mind that acetone is the oxidative ketone. Beta hydroxybutyrate is the non-oxidative ketone. Beta hydroxybutyrate is the oxidated ketone. So when you do urine ketones, your urine ketones may be low, but as you become oxidative, your beta hydroxybutyrate is going to increase and convert your acetate from beta hydroxy to beta hydroxybutyrate. So if you see your ketones go up as you begin to correct your DKA, that is considered to be normal and actually appropriate in treatment. Using insulin treats to these 2 disturbances that we talked about, ketoacidosis, and it corrects hyperglycemia. If your anion gap is not corrected or blood sugar is not decreasing, then increase your drip to about 1.5 to 2 times. If your blood sugar is less than 130, but your anion gap is still not corrected, you don't decrease your insulin to make sure the patient doesn't get hypoglycemic. You then need to add sugar, because keep in mind, we're trying to drive energy back into the cell, D5 or D10 at 100 to 200 cc's an hour. Once then your anion gap is corrected, you can titrate your insulin to your blood sugar. When your blood sugar is less than 130 and your anion gap is less than 14, you can reduce your insulin drip, and you can add IV glucose if not done, or you can also begin to transition the patient to food if her nausea and vomiting has been taken care of. One of the tricks that I like to use when a patient comes in diabetic ketoacidosis is to give them their long-acting insulin, such as glargine, so that when the patient comes off her drip, she already has long-acting insulin on board, and so the only insulin, her basal insulin, is there. So you only need to give bolus insulin in order to make sure that the patient, is able to eat without worrying about having to cover her needs throughout the day, except for her bolus insulin, because her basal insulin is already on board. You can consider switching to sub-Q insulin when the patient's anion gap is normalized, when it's less than 130, when the patient only is using less than 2 units per hour, and she's able to eat. Again, you need to overlap your drip with your sub-Q insulin by 2 to 4 hours to avoid ketosis. This is best taken care of by giving your long-acting insulin when you begin your insulin drip. In type 2 patients with DKA, they don't necessarily have to be DC'd on insulin once you correct whatever acute stress has resolved. Many of these patients can do well on oral medications such as metformin and can go back to their previous medications. What about other treatments? These patients do not normally need bicarbonate, even though they are acidotic. You should only give bicarbonate if their pH is less than 6.9 and there's evidence of cardiac instability. The dose is listed here. Phosphate is not routinely recommended. The only time you worry about hypophosphatemia is when you have muscle injury such as in rhabdomyolysis, unexplained congestive heart failure, respiratory failure, or severe confusion. But again, routine phosphate administration is not recommended. Well, what about cerebral edema? Usually only in children. However, think about the fact that that some of our patients may be 14 years old, 13 or 14. So we have to think about that because they are still pediatric in how they may respond. So if they have a persistent decreased loss of consciousness despite DK, the standard treatment for diabetic ketoacidosis, you need to do the CT scan to confirm the diagnosis of cerebral edema. And in older patients, maybe even other causes such as stroke, and again, appropriate medications, Decadron and mannitol. So we monitored the patient. She's in the ICU if her pH is less than 6.9. We've given her IV fluids. We replaced her potassium, making sure that we pay attention to whether or not the patient has good urine output. We started her IV insulin. The last thing we need to do is identify the cause. Keep in mind that ketones are neuroregulatory at the level of the uterine artery. This is why we clear ketones in obstetrics. In no other place if people are just ketotic, do we give IV fluids. And in fact, many of the common American diets actually work on producing ketonuria. However, in pregnancy, it may cause uterine artery vasospasm and result in significant fetal heart rate abnormalities. But again, as I've said, you cannot deliver the fetus unless you have stabilized the mother. If your mother is not metabolically stable, your fetus is not going to be metabolically stable, and you may end up losing both the mother and the fetus. Well, let's talk a little bit about thyroid storm and thyroid disease. The thyroid is the second largest gland in the body. It's really located here right on your neck, as we all know, below the sternocleidomastoid muscles, and it's controlled by the hypothalamus and the pituitary. The thyroid is really important because it functions to maintain metabolic processes. It produces thyroid hormones, T3, the triiodothyronine, and T4 thyroxine. These hormones will help to regulate metabolism and affect the growth of other systems in the body. The thyroid is very important, and we're going to talk about, in this particular case, hyperthyroidism, but even hypothyroidism can cause significant effects. In addition to that, a poorly functioning thyroid can result in hypercalcemia because the thyroid secretes calcitonin to lower calcium levels, and the parathyroid sit back on the back of the thyroid to secrete, to raise calcium levels. So if any one of these is out of whack, you can get into trouble. Recently, I've had several patients with nausea and vomiting who've actually had hyperparathyroidism. So with elevated calcium, that's something always to think about. The hormones of the thyroid are thyroid stimulating hormone, which is in the pituitary. It is controlled by thyroid tropin releasing hormone. Now, keep in mind that TSH is in the same family of hormones as FSH, LH, ACTH, MSH. So the alpha subunit looks the same, the beta subunit looks differently. This is why in pregnancy, it can appear that your thyroid is low or that you have hyperthyroidism, but we're going to talk about how to make that diagnosis so that you're not over-treating people just because of the changes in hormone. It functions to stimulate the the thyroid, and it may enlarge the thyroid when it's underproducing. The other time you get an engorder, of course, is in pregnancy. And so therefore, if you are feeling the neck and the thyroid feels exceptionally big, it is important to make sure you get thyroid hormones. Counterintuitively, a high TSH indicates low thyroid hormone because it's having to keep on trying to beat the thyroid up to make thyroxine and triiodothyronine. And a low TSH may indicate hyperthyroidism, except in pregnancy, we have to be careful to look at other parameters. It functions to stimulate skeletal muscle development, O2 consumption at rest. That's why people with low thyroid sometimes have a decreased basal metabolic rate. It stimulates bone turnover. And so therefore we'll talk about some of the complications of thyroid disease. It makes the heart work appropriately by promoting chronotropic and ionotropic effects. It increases the number of catecholamine receptors in the heart. So if you have low, it can make the thyroid heart beat too fast or too slow. It's associated with anemia. And then of course, as we talked about, metabolism. There are two hormones, T3 and T4. T3 has 3 iodinated areas. So that's the iodothyronine, and T4 is the tetraiodothyronine. These are stored in follicles in the thyroid and are filled with a protein called thyroglobulin, which increases in pregnancy. As if people do not get enough iodine, the follicles where it's stored as T3 or T4. T4, the 4, is converted to T3 for use by your peripheral organs such as the kidney, liver, and spleen. Therefore, somebody in renal failure may also have problems with appear to have problems with their thyroid. The one thing that people need to understand is T3, when you take off one of those iodines, is 10 times more active than T4. So only about 20% of total T3 is secreted by the thyroid. The majority of is formed from a catalysis of T4 by the liver and the liver. So therefore, like I said, you have to have a functioning liver and a functioning kidney in order for you to have optimal thyroid function. Like I said, T4 has 4 iodine atoms, is a slow-acting pre-hormone. It takes 4 days to peak in blood with a half-life of 7 days. But it can take up to 6 weeks. T3 is active and immediate, and its half-life is very short, about 1.5 days. So let's talk about those labs we're talking about. In hyperthyroidism, you need to have 2 things. An elevated free T4, because remember I told you the thyroglobulin was increased in pregnancy, so it's going to bind thyroid hormone. So you need to get free thyroid hormone. Free T4 or a free T3 and a decrease in your TSH. In hypothyroidism, you don't need to have a decrease of your free T4. You just need to have an increase in your TSH above normal levels to have an appropriate diagnosis. Well, let's talk about Graves' disease. Graves' disease is the most common form of hyperthyroidism. It is an autoimmune disease, which is due to circulating thyroid antibodies. These antibodies can also cross the placenta and affect the fetus. Rarely do they cause problems, but they can cause hypothyroidism or hyperthyroidism in the fetus. The hyperthyroidism is much greater in women, and of course, it peaks in women during childbearing years. Everybody who has ever seen anybody with hyperthyroidism, this is the particular, this is a very pathognomonic picture. Weight loss, these are the symptoms. Tachycardia or fast heart rate. Exophthalmos or bulging eyes, which is kind of what people think about when they think of thyroid disease. Nervous and anxious, they're hot, they cannot sleep. They have frequent bowel movements, not diarrhea, but they just go to the bathroom 2 to 3 times a day, and they may have a goiter. I remember diagnosing one of the little girls at my church with hyperthyroidism. And I distinctly remember that when she would come and lie on me, I could just feel her heartbeat. And then she had something else that is accompanied with exophthalmos, which is an eyelid droop. So any of those things are associated with the symptoms of hyperthyroidism. What are the complications of hyperthyroidism? Atrial fibrillation, myocarditis. I recently took care of a patient with twins who probably had hyperthyroidism uncontrolled much longer than she had was aware, and she had significant myocarditis resulting in ST elevation of her EKG, and us having to cath her to make sure that she was not having any other ischemic issues. And then long-term cardiomyopathy. Remember, the thyroid regulates how the heart works, catecholamines, inotropic effects, chronotropic effects. All of those things are very important for cardiac function. Osteoporosis, remember, it helps with bone turnover. So if your bones don't turn over, they become brittle and osteoporotic. And then last but not least, thyroid storm. Thyroid storm is a life-threatening syndrome.
Good morning.
It's really just decompensated hyperthyroidism. I took care of a patient who once told me that God told her not to take her thyroid hormone, and she was in fulminant cardiac failure with the worst pulmonary edema I had ever seen in my life. So you have to, when people do not take their medications and are not well controlled, it's like a meltdown. One of the things we have to be careful, though, is not to confuse this with preeclampsia. People with thyroid disease are tachycardic and usually have a fever in addition to their hypertension. They're agitated, confused, they psychosis, probably that's why she thought God told her not to take her thyroid medication. Nausea, vomiting, abdominal pain, and then of course the tachycardia, like I talked about, associated with congestive heart failure. The treatment for this is PTU, propylthiouracil. Unfortunately, it does not come in a liquid. So if the patient it cannot swallow pills, you'll have to put down some type of nasogastric tube to get it in. It doesn't come in any other IV form. So this is one of the challenges in caring for these patients, but you can get it down through an NG tube. 200 to 400 milligrams PO every 4 to 8 hours. And then you have to start your PTU prior to starting your iodine. Do not start iodine because you're trying to convert T3, which is more active, to T4, but please do not start that iodine until you have your PTU on board. And these are 2 sets, potassium iodine or Lugol solution. After you get your, you can also use glucocorticoids, but I love glucocorticoids because glucocorticoids block that conversion of T4 to T3. Remember that T3 is a fast-acting hormone, and we really want to do that. So you can use hydrocortisone or dexamethasone. And then for heart rate, esmolol, if the patient is unable to tolerate oral, that's an IV. You can use 500 mics per kilo per minute for blood pressure and for tachycardia. However, I prefer propranolol if the patient can do propranolol by PO or NG, because it also blocks the conversion of T4 to T3 and is useful. So in conclusion, diabetic ketoacidosis is a life-threatening event for both the mother and the fetus. We must stabilize the mother first before anything that is a priority. Keep in mind that diabetic ketoacidosis is associated with hyperglycemia, ketosis, and acidosis, and the use of insulin and fluid is to address all of those. And then thyroid storm is a rare complication during pregnancy. Emergency treatment is crucial
and includes how we've outlined it. PTU followed by iodine, steroids, and beta blockers. I thank you for your attention. And I look forward to your questions in the question and answer session.
So we thank Professor Graves for sharing from my experience. DM in pregnancy is increasingly something that we'll see in our obstetric population, especially given the fact that our women, the change in lifestyle and change in diet. So we're going to be having, if we're not speaking, can we please mute our mics, please? Okay. So we have, with the change in lifestyle, sedentary lifestyle, and change in diet, we have increasingly seen patients with diabetes. While thyroid stomach, she pointed out, is not very common, but you do occasionally see patients like that. And I think it's good that we have had this opportunity to improve our knowledge. We will now move on to something that may be a bit more familiar to a lot of us, which is hemorrhage, something we see every day. But let's see how in other climes people address this challenge, which is very high on the list of causes of maternal mortality worldwide. So to take this, we have Dr. Sonia Abdelrazak. I hope you can all see my...
Good afternoon.
Okay.
My name is Sonia Abdelrazak, and I am a maternal fetal medicine and critical care specialist at Yale University in Connecticut in the United States. It is my privilege to speak with you today on the subject of obstetrical hemorrhage and its management, and I thank you for this opportunity. I have no financial interest to disclose. And at the conclusion of this talk, I hope that you'll be able to discuss the leading causes of obstetrical hemorrhage, identify patients who may be at risk for obstetrical hemorrhage, and discuss evidence-based modalities for the management of obstetrical hemorrhage. Obstetric hemorrhage can be looked at across the spectrum of pregnancy, ranging from the earliest bleeding in early pregnancy, and then more commonly, antepartum hemorrhage, which is bleeding that occurs after estimated gestational age of 24 weeks, and most commonly, postpartum hemorrhage. Postpartum hemorrhage is further described as primary, which occurs within 24 hours of delivery, or secondary, which occurs 24 hours to 6 weeks after delivery. The definition of obstetrical hemorrhage itself has been variably defined. Different resources will define obstetrical hemorrhage as an estimated blood loss of more than 1.5 liters, a decrease in hemoglobin of greater than 4 grams, or an acute transfusion requirement of more than 4 units of packed red blood cells. In 2017, the American College of Obstetricians and Gynecologists redefined postpartum hemorrhage specifically as estimated blood loss of greater than 1 liter with signs and symptoms of hypovolemia within 24 hours of the birth process. As postpartum hemorrhage comprises the vast majority of obstetrical hemorrhages, many of our future slides will focus on this particular aspect of obstetric hemorrhage. Postpartum hemorrhage is the leading cause of maternal mortality worldwide. 35% of all maternal deaths are due to postpartum hemorrhage, according to the World Health Organization and UNICEF. That is 14 million women annually across the world experience postpartum hemorrhage. The risk of maternal mortality from hemorrhage itself is approximately 1 in 1,000 deliveries. Between the years of 1990 and 2010, there was a global reduction in maternal mortality from 543,000 to 287,000. The MMR, or maternal mortality ratio, itself decreased from 400 per 100,000 live births to 210 per 100,000 live births. There is, however, a reproducible disparity that is described between developed and less developed countries and the experience of postpartum hemorrhage. 99% of maternal deaths that are attributable to postpartum hemorrhage occur in less developed countries versus 1% of similar deaths that occur in developed countries. For the remainder of this talk, we will next discuss physiology of pregnancy, followed by causes of obstetrical hemorrhage, risk factors lending toward hemorrhage, the etiologies of hemorrhage itself, and the treatments and management therein. Some brief physiology. Cardiac output in the gravid woman increases by about 50% throughout the duration of the pregnancy. Stroke volume increases by approximately 25%. The blood volume increase in a gravid woman is notable for approximately a 30% increase, or 70 milliliters per kilogram up to 100 milliliters per kilogram throughout the course of the pregnancy. What these physiologic changes mean are that even within the setting of a hemorrhage, a gravid or newly postpartum woman may only show signs of tachycardia until approximately 30 to 40% of her blood volume is depleted. Then hypotension and peripheral vasoconstriction will be noted. So by the time she may show these symptoms, she is significantly compromised. Uterine and ovarian arteries also increase flow from less than 5% of total volume up to 12% of cardiac output, thus explaining further as to why blood loss can be so significant during childbirth. Again, the overview of obstetrical hemorrhage encompasses early pregnancy, which mostly occurs in the setting of abortion or ectopic pregnancies with rupture, but more commonly occurs with antepartum hemorrhage and postpartum hemorrhage. Antepartum hemorrhage may be displayed as placenta previa, placenta abruptio, placenta accreta spectrum, trauma, or uterine rupture. Postpartum hemorrhage, and I apologize for the small font on this slide, but postpartum hemorrhage, again, it can be further described as primary, in which scenario the main causes are uterine atony or contraction abnormalities, which comprise of 70 to 80% of all of the primary postpartum hemorrhage. Examples of this are an atonic uterus, uterine inversion, or an overdistended uterus. Another etiology may be retained placental tissue, for instance, retained placenta or a placenta accreta spectrum disorder, genital tract trauma, and coagulopathies, inherited or acquired. Secondary postpartum hemorrhage may be experienced in the setting of retained products of conception and sepsis. The risk factors for obstetrical hemorrhage are numerous. Again, focusing on postpartum hemorrhage, we have uterine atony with a variety of risk factors: prolonged use of oxytocin, high parity, chorioamnionitis, multiple gestation, polyhydramnios, and multiple fibroids, lending toward poor contractility of the uterus. Genital tract causes lending toward risk factors of operative delivery, precipitous delivery, and macrosomia. And finally, retained placental tissue, experience possibly as previous uterine surgery of any variety, or for instance, a subcenturiate lobe of the placenta. Again, antepartum hemorrhage may be noted in the setting of placenta previa, abruptio, or uterine rupture, and postpartum hemorrhage, to summarize, is seen most often with uterine atony, but also may be experienced significantly with retained placental tissue of any etiology, trauma, or uterine rupture. The response to any type of obstetrical hemorrhage should be multidisciplinary with a multifaceted approach, with the goal of maintaining maternal hemodynamic stability while simultaneously attempting to identify and treat the cause of that specific hemorrhage. The initial management of hemorrhage is the same irrespective of its etiology. It requires the examination of the gravid woman or postpartum woman and initiation of maternal resuscitation with the goal to restore normal volemia and normothermia. 2 large bore IVs should be placed, rapid infusion of intravenous fluids, supplementation to optimize oxygen carrying capacity through the blood. Laboratory evaluation, if available, can be helpful, specifically looking at the complete blood count. Coagulation screening, if available, also is helpful, looking at the coagulation profile of prothrombin and prothrombin times. Blood product availability will vary depending on location. And throughout all of this, the maternal vital signs should be monitored, as well as fetal well-being if the mother is still pregnant. Management of obstetrical hemorrhage may be undertaken via a variety of modalities. What we'll discuss in the next few slides is medical management. Oxytocin is a uterotonic that is a first-line agent in the management of postpartum hemorrhage. It's given as a slow bolus injection, and if given rapidly as an IV bolus, it may precipitate hypotension and tachycardia. So this route with a rapid push should never be done. Methylgonavine is an ergoalkaloid, also known as Methergin in the United States, and it causes uterine and vascular smooth muscle contraction. It is dosed as 0.2 milligrams given intravenously or intramuscularly. It may cause hypertension, often causes nausea or emesis. And a relative contraindication to its administration is maternal hypertension or preeclampsia. 15-methylprostaglandin F2 alpha, also known as carbaprost or Humabate, is often used for bleeding that is unresponsive to oxytocin or the ergoalkaloid. It's dosed as 0.25 milligrams every 15 to 30 minutes intramuscularly or intramyometrially for a total of 2 milligrams if needed. It is most often associated with bronchospasm, flushing, nausea, and emesis, and its contraindication is asthma due to its propensity toward bronchospasm. Pulmonary shunting may cause maternal hypoxia in larger doses. This is a table that summarizes the last couple of slides, looking at oxytocin, methylgonavine, 15-methylprostaglandin F2 alpha, and misoprostol. Misoprostol itself is given, is dosed in tablets and is given 600 to 1,000 micrograms either orally, sublingually, or per rectum. And its most common side effects are nausea, emesis, fever, and shivering. A more recent development in the realm of medical management for postpartum hemorrhage is tranexamic acid, or TXA. This is an antifibrinolytic agent. It is given intravenously or orally. The notable trial that was associated with was the Woman trial, or the World Maternal Antifibrinolytic Trial. It was a double-blinded, randomized controlled trial that involved 193 hospitals in 23 countries from March 2010 and concluded in April 2016. Over 20,000 women were enrolled in this study, and TXA was given as 1 gram IV over 10 minutes. What was significantly found was that death due to obstetrical bleeding was statistically significantly reduced in those women who received tranexamic acid. So it now is a modality for obstetrical hemorrhage. It may be given a second time as well within 24 hours. Moving beyond medical management are tamponade techniques. Manual compression should be undertaken during the initial resuscitation of the mother and examination for the cause and etiology of the hemorrhage, and can be performed with one operator or two operators to assist one another. Intrauterine tamponade or packing also may be used. There's limited evidence with the use of intrauterine tamponade and packing. However, in several larger studies, specifically the study listed here by Lekas, 86% of women with balloon tamponade placed did not require further procedure or surgery. And in the largest summary study of its kind, 75% of women did not require further treatment after intrauterine balloon insertion amongst 114 women with postpartum hemorrhage. In another study by Jung et al., intrauterine balloon and compression sutures were found to also be beneficial in some instances of postpartum hemorrhage when used simultaneously. Tamponade techniques may be used as definitive management, potentially with some responsive postpartum hemorrhages, but also may be used as a temporizing method until one gets more access either to supplies or the operating suite, or if interventional radiology is available for embolization, transporting patient to that destination. This slide summarizes different tamponade techniques that are currently recognized for management of postpartum hemorrhage. The intrauterine balloon tamponade devices that are currently commercially available are the Bakri balloon, which is a balloon that is inflated with 300 to 500 milliliters of saline and left within the uterine cavity for a specific period of time, and then slowly deflated over time as the effect of the tamponade ideally has quenched the postpartum hemorrhage. The Ebb uterine tamponade system is another type of intrauterine balloon. It is a double balloon system that involves a uterine component, which will hold up to 750 milliliters of fluid, and a vaginal balloon component, which will hold 300 milliliters of fluid. Additionally, a Foley catheter may be used if one of the intrauterine balloons is not available. And the recommendation is to insert one or more 60 milliliter bulbs into the uterine cavity, and then fill each inserted bulb with 60 milliliters of saline. Finally, uterine packing has long been the treatment of choice to manage postpartum hemorrhage prior to having commercially available balloons. It is safe, quick, and effective in a majority of cases. And even in resource-poor areas, often supplies are available that may be utilized in this scenario. Ideally, a 4-inch gauze that is pre-soaked with 5,000 units of thrombin in 5 milliliters of saline is used and inserted, extending from cornea to cornea with either an instrument or manually if the provider is able to place their hand that far into the uterus. A strip of the individual gauzes are tied together securely. A reproducible count is imperative in this situation, and part of the gauze is left to wick out of the uterus and into the vagina, and this packing is removed in approximately or within 24 hours. Another modality for management of hemorrhage is uterine artery embolization. Uterine artery embolization is a less radical approach to control bleeding. It has become a well-recognized alternative method of treatment in the conservative management of postpartum hemorrhage, particularly in association with local or medical treatment, or in the event of their failure. It ideally avoids morbidity associated with a peripartum hysterectomy and may preserve fertility. It's also an additional option for when arterial ligation or hysterectomy has failed to control bleeding. It was first described in the medical literature in 1979. And since then, several reports have demonstrated its safety and efficacy both in the treatment of major hemorrhage as well as in its prevention. The ideal candidate to undergo uterine artery embolization is someone who is hemodynamically stable but demonstrates persistent slow bleeding. Also, as mentioned, a woman who has failed less invasive therapy may be a candidate for this as well. Outcomes are reported to be as successful as 89% median for postpartum hemorrhage with the use of uterine artery embolization. And in one study of 114 uterine artery embolization procedures, the median success was reported as 80%. The risks are infertility, preterm birth, and fetal growth restriction in subsequent pregnancies. And the most severe complications of venous thromboembolic event, uterine and/or bladder necrosis, and neuropathy, though again very severe and have been reported, are fairly rare and occur in less than 5% of cases. We'll now move into the surgical management. We'll step back just for a moment to look at where we have journeyed thus far in a discussion of management. An attempt at manual removal of the placenta or retained products during the evaluation and inspection for etiology or source of hemorrhage should be undertaken. We looked at medical management so far. We've discussed uterine packing and intraballoon devices. A curettage, either sharp or by suction, may be performed as well to attempt for more removal of retained products if that is thought to be the cause of hemorrhage. We then discussed embolization, and we'll move on to surgical at this point. The surgical management of postpartum hemorrhage may involve vascular ligation, specifically and first of the uterine arteries bilaterally. If that does not sufficiently stop the hemorrhage, then consideration may be given to ligating the utero-ovarian vessels, followed by traditionally what was described to be the hypogastric artery ligation, which is a much more significant surgical procedure that also requires a retroperitoneal approach And in the day and age of embolization availability and medication availability, hypogastric artery ligation is less, more often now described in literature and texts as opposed to use currently. The point of vascular ligation is to diminish the pulse pressure of the blood flow to the uterus. And its overall median success rate for all types of vascular ligation are reported to be 92%. There are more recent reports that the hypogastric artery ligation was not as successful as once thought either, which is an interesting historical note. Uterine compression sutures are another option for surgical management. They are reported to be 60 to 75% effective for stopping the postpartum hemorrhage. One type of uterine compression suture is the B. Lynch. It is the most reported in the medical literature and thought to be likely the most used type of compression, the most performed type of compression suture. A large, rapidly absorbed suture is placed from the cervix to the fundus, around to anteriorly and then around the posterior aspect of the uterus, and then back down across the fundus into the cervix, causing a physical compression of the uterine body. And if that does not stop the postpartum hemorrhage, then the option of hysterectomy, which is the most severe and significant surgical maneuver for a woman who is hemorrhaging, may be undertaken. Considerations for anesthesia. Type of anesthesia is generally determined by the maternal and fetal status. Hemodynamic instability generally lends toward general anesthesia choice, and central line access in this scenario should be strongly considered, particularly in the event that a massive transfusion may be employed. Now going into transfusion options. A massive transfusion itself is described or defined as 10 or more units of packed red blood cells given within a 24-hour period, or 4 units of packed red cells in 1 hour. Massive transfusion protocols utilized within the obstetric community are largely extrapolated from protocols developed within the world of trauma. Most centers will report at this point a ratio of packed red cells to fresh frozen plasma to platelets of 1 to 1 to 1. Historically, and varying across geography, the ratio of these particular blood components to one another were reported in varying ratios, but most widely accepted today is the 1 to 1 to 1 ratio. Additionally, in larger urban centers and referral centers, blood transfusions may be targeted more specifically with elastography measurements or point of care testing for coagulation that allow for specific blood products to be pinpointed and thereby transfusion direction according to the need for a specific blood product, specifically, for example, the TEG unit or a ROTAM unit. The most common side effects for massive transfusion are hyperkalemia, hypocalcemia, hypothermia, and acidosis. Other therapies that are notable in the management of postpartum hemorrhage are intraoperative cell salvage. The benefits of using this modality are that there's a decreased risk of homologous transfusion, and that the cost of maintenance for transfusion and blood bank usage may be minimized. However, the cons of this therapy are that there are reports of anaphylactoid syndrome of pregnancy or amniotic fluid embolism occurring in this setting, as well as concern for contamination with fetal debris, or isoimmunization for the mother. A separate suction setup is required, and a leukocyte depletion filter is also required to administer the salvaged blood. Autologous donation or normal volemic hemodilution are not usually pursued because there are considerations of fetal well-being and difficulty in identifying which women were most likely to hemorrhage, despite being able to identify their risk factors. A few additional therapies that are worth noting are recombinant factor 7. This is a vitamin K-dependent serine protease. In the United States, the Food and Drug Administration have approved the use of this medication only in the treatment of hemophilia A and B. Its use in postpartum hemorrhage is controversial. In one study in 2007, this particular factor 7 was shown to improve obstetrical hemorrhage. However, there were also reports of potential for life-threatening thrombosis, and that was reported in between 2 to 9% of women who received this. Therefore, it is not considered a first-line therapy, and it is reserved for extenuating circumstances and usually used under the direction and guidance of a coagulation specialist. Additional therapies are prothrombin complex and fibrinogen concentrate. These are human plasma-derived concentrates of vitamin K-dependent clotting factors. They are first-line treatment for acquired factor deficiencies, and they come in different preparations. One preparation is comprised of 3 factors, 2, 9, and 10, and a second available preparation is comprised of 4 factors, 2, 7, 9, and 10. Currently, there's limited data available for the efficacy of these concentrates in the setting of postpartum hemorrhage and obstetrical hemorrhage, but they are used in larger referral centers. Finally, multiple studies through the literature have supported and endorsed the use of obstetrical hemorrhage and postpartum bundles to develop protocols for the management and the standardization and uniformity of medication usage to manage these types of hemorrhages. Additionally, these protocols and bundles allow for roles to be clearly defined within this multidisciplinary team that ideally is caring for this patient. Major societies throughout the world and multiple studies have shown that regular simulations, whether they are just practice, bare bones type of simulations that occur in a regular scheduled fashion, or in today's age, virtual simulations that review medications and surgical options and all of the modalities available to care for hemorrhage are encouraged and shown to be effective in lending toward multidisciplinary care effectively. These regular simulations also ensure familiarity with protocols, adjustments to these protocols, and also allow for identification of deficiencies within the protocol themselves or within the care setting or within the care teams. So in summary, there are numerous risk factors for obstetrical hemorrhage. Management of obstetrical hemorrhage should be multidisciplinary and multifaceted. Less invasive methods should be used initially when possible, with the progression to more aggressive or invasive modalities for the preservation of life. There are medical, tamponade, embolization, and surgical modalities for management. And again, I thank you for your attention and for this opportunity. Enjoy the rest of your conference.
We thank Professor Abdel Rakez for her presentation. Professor Graves, before we take the next presentation, I don't know if you want to make a few comments or we should just go right ahead. I don't know if Professor Graves is still here. Okay, but like I said, we thank her. She has talked about obstetric hemorrhage, something that is quite common with us here. We have listened to, well, I'll say tantalized us with some of the things that we may not have readily, but I always believe that we can wish. Oh, Professor Graves, you want to say a few words before maybe the next, or we should go right ahead?
Absolutely. We were open. We want to make sure that people have their questions answered. So at this time, if you want to put your questions in the chat, we'll be happy to answer those questions or having a discussion regarding the first lectures that we've had.
Okay. Well, maybe I should start. There are one or two questions. There's a question, I can't remember how to put it there, but the speaker did not mention, that's the speaker on obstetric hemorrhage. Like I said, something quite common with us. But the speaker didn't mention the use of carbetocin for the medical management of acute bleed. Is it that it is something that is not used so frequently in your setting? Carbetocin for obstetric hemorrhage.
Can you repeat that again? What's used?
Okay. You can see it in the chat box. Let me just bring that up.
We're beginning to use carbetocin more frequently, and you didn't mention it. So we're wondering because you don't have experience with it in your setting. Carbetocin.
I can jump in. This is Elizabeth Springer.
Oh, okay. Professor Springer.
It is used. It is not FDA approved in the US, so we don't use it. I don't know why it is not FDA approved, because it's used, it's starting to be used more around the world. But we don't commonly use it because it's not approved.
Oh, okay. So that's why Dr. Sonia didn't mention it then. Okay. Then there's another question. If you have questions, please, you can indicate by a show of hands. There's another question. She talked about using chromic catguts for B-Lynch. And then the question is, what if you don't have B-Lynch, but you have Vicryl? Will that do? Which is what I must say we use quite a bit of. So, I mean, will the Vicryl do, or is there something against that? I can put it in the chat.
For the B-Lynch suture?
Yes, for the B-Lynch. Can you use Vicryl? What's your experience with? Because she mentioned chromic.
Yeah, I use whatever long suture that's available. So you can use Vicryl, you can use chromic, you can use PDS, or you can use Ethelon. Any of those sutures, any long suture with a large needle that will keep your uterus in place is acceptable.
Okay. Thank you so much. Okay, so a third question here. She talked about the ratio of 1:1:1 for massive obstetric hemorrhage for the packed cells, fresh frozen plasma, and platelets. But sometimes that is not something, especially the platelets, that is readily available with us. And what is your experience, or what is your advice in settings like that? Because I know that can be challenging. I mean, the ideal is if you have the 1:1:1, but sometimes you just don't have the platelets to use.
So one of the things you can use, do you guys have whole blood available?
Whole blood, yes, we use whole blood. We have whole blood.
Then you can use whole blood as a substitute.
Okay. So that's what we use most of the time. We just go ahead and use whole. Okay.
And actually, in the United States, here we're beginning to use more whole blood for transfusion, because when you do 1:1, that's basically whole blood, the components of whole blood without the platelets.
Okay. There's another question here. They're appreciating you for the wonderful presentation. And then can you elaborate more on the use of tranexamic acid practically? What is the minimum dose per day? and for how long can one use it and at what dose? So maybe just a few statements about tranexamic acid.
So in the woman study, tranexamic acid was used. It should be used within 30 minutes of bleeding when appropriate. The dose is 1 milligram. You can use a 0.5 milligram, and you can repeat it in 30 minutes as well.
Okay. Okay.
You want to not, after 3 hours, the use of tranexamic acid, actually the efficacy goes down. So if you have someone who's bleeding, you want to use it as soon as you think that you're getting a little bit into trouble at the very beginning, and not wait until you have massive transfusion.
Yes, yes. Thank you so much for that. Professor String, I don't know if you have any other comments, or we can just go ahead with the other lectures now.
I think we should go ahead with the other lectures.
Okay, thank you. So the next lecture we have here that we'll be taking is by Professor Thunberg, the cardiac disease. So I'll just put that up. Just a minute, please. Yeah, here we go. Cardiac disease. Okay, so I'll just share my screen now. Okay.
Hello, my name is Lorelei Thornburg. I'm from the University of Rochester in Rochester, New York. Thank you so much for inviting me to be part of this presentation. Today I'm going to be talking about cardiac disease in pregnancy. If you don't know where Rochester, New York is, which I certainly didn't before I moved here, we're on the upper border of New York. We're about an hour and a half outside of Niagara Falls. And this is a waterfall that's about 45 minutes from my house. And if you want to test your own cardiovascular fitness, you can ice climb it this time of year. So I have no relevant disclosures, although I do have a book and I teach at the SMFM course. I will not be discussing any off-label use or investigational use. My learning objectives are to talk about congenital and acquired learning cardiac lesions, to describe medication safety, and to understand best practices around labor management and cardiac disease. So I'm going to start by talking about maternal mortality in pregnancy. And when we look at all-cause pregnancy-related death in the United States, which is where I live, you can see that direct pregnancy causes and clotting disorders account for a large percentage of this. However, cardiovascular disease, including pre-existing cardiac disease, as well as cardiomyopathies, account for together 25% of maternal mortality. So about 1 to 4% of pregnancies have cardiovascular disease, and congenital heart disease as well as acquired heart disease are both on the rise. If we look at just acquired heart disease alone in one state, Illinois, 22% of maternal deaths were related to some version of cardiovascular disease, with 97% of this being acquired heart disease. Congenital heart disease has a stable maternal mortality at about 0.5% and 11%, respectively. Risk factors for cardiovascular disease in pregnancy includes age over 40, and this raises your cardiovascular disease risk of death about 30 times. Race and ethnicity are also common risk factors that are cited, especially for non-Hispanic Black women, and this appears to be independent of other variables. Hypertensive disorders in pregnancy and pre-pregnancy obesity, as well as prior cardiac disease, all increase the risk of a cardiac event in pregnancy. Congenital heart disease, about 2% of maternal cardiovascular disease is congenital heart disease, and it is the most common type as a group affecting pregnancy. It is increasing in frequency, and since 2005, there are no more adults with cardiovascular disease related to congenital heart disease than children. And this prevalence is also rising for the most complex versions of congenital heart disease. Your things like your hypoplastic lefts as opposed to your ASDs or VSDs. And this is because most patients who are born with congenital heart disease will now be able to reach adulthood and reproductive age. Pregnancy is not an automatic exclusion for these patients, but it does pose an increased risk. And evaluation and consult prior to conception is ideal. And you have to remember that even in a single lesion group, for example, ASD or VSD, different lesions can behave very differently. And so a patient's personal history needs to be taken into account. This is what I was talking about with congenital heart disease being stable in children, which are the purple lines, and rising in adults, which are the red lines. So we can see from 2000 to 2010, both all types of congenital heart disease, as well as severe congenital heart disease, have been relatively stable in children. However, the percentage or the number of people with adult congenital heart disease has markedly increased over these last 10 years. And this is because children are living longer into adulthood with these diseases, and the treatments and therapies have gotten better. So when we think about things that are, our passion projects, the hill I'm going to die on is under treating cardiac disease is not good for anyone, mother or baby. And no patient should be denied standard cardiac therapy simply because of pregnancy. And that there is no medication that we can give that is as dangerous as cardiac arrest during pregnancy. So this is one question that I, as an MFM, often feel is a great question to ask my consultants. What therapy, surgery, imaging, medication, etc. would you do if she was not pregnant? And this can be a great way to open the conversation, because oftentimes with consultants, you'll get the answer, well, we can't do anything, she's pregnant. That's okay. Tell me what you would do. And often that opens and I can say, yeah, that's totally fine. We can do that in pregnancy. I can help keep her safe through that. And that may be that they don't recognize what can and cannot be done in pregnancy safely. So let's talk about evaluating pregnancy risk, getting ready for pregnancy and evaluating the risk of an event. So pregnancy is in general very well tolerated with most cardiac disease. However, there is a 40% increase in blood volume with pregnancy. You get a drop in your SVR and your PVR, so your resistance drops, and you get an increase in your heart rate with little change in your blood pressure. And this creates a 30% increase in cardiac output during pregnancy. During labor, this increases even further. So you get a 60% increase. Your cardiac output is 60 to 80% higher than your baseline. You have heart rate and blood pressure changes related to labor. Volume changes. You get increased blood volume with each uterine contraction as you have compression of the vasculature of the uterus. Increased venous return during that time, as well as with Valsalva. And then you get acute volume loss with pregnancy, with delivery, as well as an auto transfusion with involution of the uterus. So pregnancy risk kind of as a broad brushstrokes. Regurgitant valve lesions are generally well tolerated. Complex lesions need to be assessed case by case. And the risk of inheritance is about 3 to 5% with most congenital heart disease, unless there's an underlying genetic disorder, for example, Marfan. And if there's a paternal, maternal, or first degree relative with congenital heart disease, a fetal echo is warranted. So when we think about heart disease, we can we can kind of classify this from lower risk, or WHO1, all the way up to extremely high risk, WHO4. And so there's no detectable increased risk in mortality when we're down at WHO1, which are things like repaired PDAs and VSDs, ASDs. Whereas those patients with pulmonary hypertension, severe coarc, aortic roots that are greater than 50 millimeters, those with severe mitral aortic stenosis are up at the extremely high end, where pregnancy is largely contraindicated. There is significant morbidity and mortality kind of rising through the types, with type 2 at lower risk than type 3 and type 3 at lower risk than type 4. And we can see some of the different lesions that we're going to encounter across those risk categories, with things like repaired tetralogy at WHO2, while Fontan circulations. When we think about acquired heart disease, there's also risk stratification. At your extremely high risk are your acquired pulmonary hypertensions, your Marfans with your aortic roots over 45, and those with postpartum cardiomyopathy with residual LV dysfunction, and those with left ventricular ejection fractions less than 30. And then down at your low risk are your mild pulmonary stenosis, your mild mitral valve prolapse, and your occasional patients with ACTB. What's not on this classification, I'm just going to draw your attention to, I'm going to move myself so you can see it, is prior MI with stenting, which is not well categorized and has to be lesion by lesion, patient by patient, looking at their personal risk profile, as well as recovered postpartum cardiomyopathy, but those who nadir less than 20%, which we know is a particularly high risk group in peripartum cardiomyopathy. When we think about event rates by class, you can see that class 1 has a very low event rate, about 3.5%, while class 4 has a very high event rate, almost 36%, with 2 to 3 all being between 12 and 22%. There are two big studies on cardiovascular outcomes in pregnancy, the first of which is the observational study called CARPREG. There were very few patients with congenital heart disease in this study. Most of them were acquired heart disease. There were over 500 women, though, with over 600 pregnancies, and 13% of pregnancies were complicated by edema, strokes, and death. A very high rate of cardiovascular death. They took those data and were able to construct, predictive factors. So the risk factors that they identified were prior CHF, TIAs or strokes, prior arrhythmia events, New York Heart Association class 2 or greater, ongoing cyanosis, left heart obstruction, and then EFs less than 40%. And if you had more than one predictor, your rate of a cardiac event during the pregnancy was 60%. So a nice way to be able to quickly categorize patients. The next big study was the Zahara study, and this included over 1,800 patients and over 1,300 completed pregnancies. Complication rates were only 7.6%, so again, very good outcomes for most patients. And the most common complications were arrhythmias and heart failure. And when they looked at their predictors of complications, again, cyanotic heart disease got onto the list, but pre-pregnancy cardiac meds was an important risk factor. Left heart obstruction also made it. Mechanical valves were identified this time, as was systemic or pulmonary AV valve regurgitation related to complex congenital heart disease. And so they also came up with a classification score with things like cardiac meds before pregnancy having a relatively low point score, along with arrhythmias, whereas things like mechanical valves and left ventricular dysfunction having relatively high point scores. And then they looked at their pregnancy outcomes related to your risk score based on their 0 to 13 point score. And you can see that when you cross at 2.5, you see a marked increase. So anybody who's got 2.5 or more, you're getting into the 40+% that will have a cardiac event in the pregnancy. And you can see that things like mechanical valve alone and left ventricular dysfunction both put you in that 2.5 category. And they validated this in several ongoing studies, but they were able to further classify this with their both derived and validation studies, and did indeed find that they were able to correctly predict. So who is pregnancy not advised for? Well, severe pulmonary hypertension, severe obstructive lesions like AS, MS, PS, ventricular dysfunction with a New York State classification of 3 or 4, those with an EF less than 30, peripartum cardiomyopathy, even recovered, dilated aortas, and severe cyanosis. So very similar between the two studies. When they looked at neonatal outcomes, premature birth and small for gestational age were both significant risks. And the predictors of poor neonatal outcomes included cyanotic heart disease, mechanical valve replacements, smoking, multiple gestations, and use of cardiac medications. So what's going to be our general approach to pregnancy, given that we have all this data at our fingertips that says most patients do well, but some patients will do poorly? Well, obviously a good history and physical is never awry, so we're going to start with that, followed by an EKG and a chest x-ray, a good medication review to find out not only what patients are on, but what they should be on, exercise testing, echo, and additional imaging as recommended. So for some patients that may simply be, echocardiography. For other patients, a cardiac MRI may be warranted to better evaluate the aortic root. If there's a question of pulmonary hypertension, remember that echo tends to overestimate pulmonary artery pressures, and cardiac catheterization is the best way to assure that you have these data correctly. Genetic considerations for those who have either congenital heart disease or an ongoing known genetic disorder, things like Marfan's. And then the frequency of follow-up does depend a little bit on what you find in this evaluation and the type of heart disease. So let's talk briefly about medications, because that was one of our reviews and one of those things that we know is associated with an increased risk of poor outcomes. So on the safe end of the spectrum, we have things like Tylenol, heparin, low molecular weight heparins, aspirin, inhaled steroids, labetalol, and nifedipine. On the do not use end of the spectrum, we have things like ACE inhibitors and probably factor Xa anticoagulants. While in the middle of the spectrum, we have a risk benefit ibuprofen, which is probably fine until steroids, which may have some risks of other complications. Metoprolol, with some data suggesting it may increase IUGR risk. Antiplatelet medications, some of which are not known if they cross the placenta or not. Digoxin and flecainide, which do cross the placenta but are significant antiarrhythmics, and you have to balance the risk and the benefit. I put this little symbol here to indicate those that are generally compatible with breastfeeding, but may be dose dependent. So I also want to just remind people that the other thing you can do is there are two great services that are here in Rochester, New York. One is Mother to Baby and one is the Lactation Study Center, and they actually are worldwide accepting of consultations by phone and by email from physicians. If you have questions about a specific medication in pregnancy, they would love to hear from you. And if you have questions about a specific medication in lactation, similarly, that group would love to hear you, and it's a doc-to-doc hotline. So how often should we be seeing these patients back? Well, the modified WHO classification for maternal risk gives us a sense of this. So those patients who were at the ones, remember, so these were our repaired ASDs, VSDs, otherwise well patients who'd had a history of something related to cardiac disease. These patients are probably not at much increased risk, have a very low rate of a cardiac event during pregnancy, can be cared for locally and delivered locally. While our patients who are at level 4 or 3 or 4 have a higher risk of these complications, should be seen frequently, delivered at an expert center. So what are we looking for when we're evaluating these patients? Well, we're looking for signs that their cardiac output is failing, because cardiac output is related to heart rate plus your stroke volume. So your preload, your afterload, and your contractility. And unfortunately, the final common pathway for all of these cardiac diseases is pulmonary edema and arrhythmias. So those are the two things that we're kind of on the lookout for all of these patients, is that their cardiac output can't keep up with their ongoing cardiac disease. Let's talk briefly about delivery mode. So most patients with congenital acquired heart disease are candidates for vaginal delivery. Some do require an assisted second stage or a cesarean. Typically, those are reserved for obstetrical indications, those who are on warfarin in labor due to the fetal bleeding risks, severe pulmonary hypertension, fixed obstructive lesions because sudden blood pressure changes can be quite challenging to manage, and those with an unstable aorta or aortic root. Anesthesia is mostly well tolerated, benefit from reduced afterload. So both of your regurgitant lesions, your atrial regurg and your mitral regurg, both benefit from a reduced afterload, and so they enjoy having their epidural. It helps their heart function. But there are other lesions that struggle with this, and those include your VSDs that have a left to right shunt, as well as your stenotic lesions, both mitral and aortic. So what if your patient ends up needing surgery on one of these valve lesions during pregnancy or any other cardiac disease? Well, the data here are very, very limited. There's one, case series of only about 21 patients. The mortality was quite low for mothers, but a little higher for fetuses. And this is surgeries, major maternal comorbidities, and early gestational ages where intervention was not possible during the events. Emergent surgery conferred the highest maternal risk. And if you do need to operate on one of these lesions, the best time is probably that 24 to 28 week spot before they get into the late third trimester with fetal monitoring. If they need bypass, high flow is best with an aim for a higher mean pressures and maintain normal thermia as much as possible. And CT surgery can be performed with relative safety based on this very small data. Again, remembering that well mothers produce well babies. The new AHA guidelines generally do not require endocarditis prophylaxis for most lesions. Isolated ASDs are more than 6 months out for most closures, no longer require prophylaxis. It's really only required for those with Marfan's, complex or cyanotic heart disease, and those with mechanical valves. When you think about your heart team, those with a category 1, it's a relatively small team, your obstetrician, your internist, your cardiac person on consultation. Whereas when you get into 3s and 4s, you really need the bigger team, depending on the patient's ongoing disease state. So you may need everything from an interventional cardiologist to a geneticist to a mental health specialist, depending on the disease in question. So when should you work up a patient for heart disease? I like this chart. I realize it's a little busy, but I'm going to walk you through it. There are 3 boxes here at the top: the blue box, the yellow box, and the purple box. And when you follow these, what you're looking for is greater than 1 symptom plus greater than 1 vital sign plus greater than 1 risk factor. If you have that combination, or you have any combination adding to 4, so this would be obviously 3 or any combination, 3 across or any combination adding to 4, so 3 in one box and 1 in another, then you really need to be getting an EKG and a BNP to be looking for cardiac disease. Results negative, you go on about your business. Results positive, then you really need to have a high index of suspicion and be talking to your MFM and your cardiologist. It gives you a nice scoring system to make sure you're being objective and thinking through those patients who need evaluation. So let's talk about cardiomyopathies, which are a little bit of a unique bird. So cardiomyopathy comes in two types, the systolic dysfunction type and the diastolic dysfunction type. Systolic dysfunction is a pump problem. They can't get the flow forward. The overflow goes backwards into the lungs, again leading to that pulmonary edema, and they need reduced volumes and avoiding hypertension and ionotropes to have their best outcomes. Whereas diastolic dysfunction is a filling problem. The fluid can't move forward and they need rate control without tachycardia, and they're very AFib sensitive. So peripartum cardiomyopathy, the classic definition is heart failure within the last month of gestation or 5 months postpartum in the absence of identifiable risk factors and the absence of recognizable cardiac disease before pregnancy. Additionally, they need left ventricular diastolic dysfunction with an EF less than 45 and a shortening fraction less than 30. Some of the tests that can be helpful for figuring that out, 90% of your cases are going to present in the first 2 months postpartum with dyspnea, orthopnea, fatigue, edema, and hypoxia. Fever is uncommon. When you're looking at your laboratory testing, you should have an elevated BNP, can help you make the diagnosis. Your chest x-ray will show cardiomegaly and pulmonary edema. So in general, you want to reduce preload, reduce afterload, and improve contractility. BNP is a way to look at how the ventricles are responding to volume, and normal BNP, as we've talked about 2 pages ago, does help exclude cardiac decompensation in pregnant people. So it's a very helpful way to assess the patient with dyspnea and suspected CHF to figure out whether you need to be going down the heart failure route or perhaps the PE route. When you think about those 3 principal things you want to do, for preload reduction, you want to use Lasix or furosemide to get fluid off. You want to improve contractility through ionotropic therapy, and you want to use beta blockers to help rate control. You also want to control blood pressure or afterload reduction by using hydralazine, Norvasc, or long-acting nitroglycerin, all of which are fine in pregnancy. And then postpartum, when they're no longer pregnant, ACE inhibitors, as long as they're on a reliable form of contraception, would be another reasonable choice. The mortality rate is relatively high with peripartum cardiomyopathy, although 40 to 45, 50% will recover. Of the patients who recover function, 50% are going to have a complete recovery of function. About 30% will have partial, and then 20% are actually not going to recover at all. They're going to get worse. So when you think of predictors for poor recovery, those who have the lowest EFs going into their diagnosis, those who have the worst fractional shortening and the biggest LV dimensions, elevated troponins and block rays. Recurrence risk can happen even if you're completely recovered, and about 50% recurrence in a subsequent pregnancy. So subsequent pregnancy decisions need to be carefully counseled, and they really should avoid pregnancy if there's persistent LV dysfunction with a high risk for decompensation and mortality. If you are going to get cardiomyopathy of any kind, peripartum cardiomyopathy has the best survival at the 10 and 15-year mark, looking at this Kaplan-Meier, compared to other types of cardiomyopathy, although obviously nobody would ask for cardiomyopathy. But if you are comparing it across, cardiomyopathies from peripartum reasons actually have the best risk profile. When you think about complex and cyanotic heart disease, cyanotic heart disease actually can be quite a risk factor in pregnancy. So data are very limited of those patients who have bad cyanotic heart disease, but poor fetal outcomes are associated with those with the highest hemoglobin, the lowest O2s, and the worst functional class. Fetal loss is upwards of 50%, as well as premature birth rate upwards of 30%. Congenital heart rate disease in the offspring is common at 5%, and about 35% of patients will have ongoing complications. Eisenmeyer's is an example of this with a large left to right shunt that produces pulmonary hypertension and reversible disease that then reverses the shunt to right to left for cyanosis. There are very, very limited data on this, but the data do suggest that these patients are very sick in pregnancy. Of these 12 cases, only 7 reached the 3rd trimester, and there were 2 deaths in pregnancy and 1 postpartum. For valvular disease, we're going to glump ASD, VSD with that. Unrepaired ASDs have a slightly increased neonatal risk. The left to right shunt is exacerbated by the cardiac output change of pregnancy, however, counterbalanced by the drop in PVR, so probably an overall net even. There is a paradoxical embolism risk, so you need to be careful in that with these patients. And there are familial types of ASD, so you can consider fetal screening. AVSD after repair is usually well tolerated, remembering that this is more commonly seen in Downs patients, which does have a transmission risk. Pulmonic stenosis is usually very well tolerated and less severe. Valvectomy can be performed in pregnancy if necessary, although ideally pre-pregnancy. And in more than 100 patients followed in this study, there were no cardiovascular events. Preterm delivery was relatively low compared to other cardiac lesions with low fetal and maternal mortality. Remembering the recurrence risk is low with the exception of Noonan syndrome, which is autosomal dominant. These patients do need to see anesthesia, however, because they are very dependent on volume, afterload, and RV contractility. So they need to be carefully balanced during their delivery between these three things to maintain their pulmonary blood flow. Aortic stenosis or narrowing of the aortic valve. These patients are unable to augment their cardiac output. So they are both preload and hypotension sensitive, which increases their risk for both CHF and ischemia. This increases their risk for poor placental perfusion, and this lesion is uniquely at very high risk for IUGR and preterm labor. And most patients with this do need to deliver in a major center. Aortic coarc is generally well tolerated. Pre-pregnancy assessment, though, is needed because there are a lot of different severities of coarc. This study had about 118 patients in it, 9% loss rate in the first trimester, 3% prematurity rate. Cardiovascular complications were uncommon, with the exception of one Turner's patient who dissected, but hypertensive disorders were common. So 30% had hypertension and 75% had hypertension if there was a significant coarc. Marfan's is a unique disorder of the aortic root, which leads to a fragility in the fibrillin of the aortic root and causes dilatation there. Widened aortas and aortic dissection, aortic regurgitation are all common, and mitral valve prolapse also. There's an unpredictable risk of maternal death from dissection, rupture, and heart failure. And so your risks in pregnancy are going to be based on the fact that this is hormonal remodeling at the level of the intima of the large cardiovascular system is common in pregnancy. And so this is going to be accelerated in patients with Marfan's. There's a fetal risk as this is an autosomal dominant condition as well. When you have one of these patients in pregnancy, aortas over 45 really are not compatible with safe pregnancy, while those less than 40 are probably reasonable if otherwise low risk. And then between 40 and 45, you need to individualize risk. These patients benefit from a beta blocker to protect that aortic root, regular aortic imaging to make sure it is not expanding, fetal echo and genetic counseling. And you want to watch for other marfanoid issues like joint issues, lens subluxation, etc. For these patients, you want to minimize shear stress and minimize increases in aortic wall tension. And to do that, you want to keep blood pressure meticulously under control and slow the heart rate with a beta adrenergic beta blocker. So, and that can decrease your chance for potential aortic root dissection. Peripartum delivery and C-section for aorta over 40 millimeters. Postpartum, the dissection risk persists up to 6 to 8 weeks, and these patients should be following up because that cardiovascular remodeling is still ongoing. And there's a high index of suspicion in these patients with any changes in chest pain. Future evaluation is an area of ongoing research in lactation due to the hormones of lactation being similar to those of pregnancy and questioning whether they continue the remodeling question. Talk briefly about mechanical valves, any type, any position, and so you need to really individualize risk. But in general, these are at increased risk of thrombosis and embolism because pregnancy increases your clotting factors and decreases your fibrinolysis. Those at the highest risk are at the low flow sites like mitral and all require anticoagulation. So when you think about anticoagulating them, you can use warfarin, unfractionated heparin, or low molecular weight heparin. Warfarin is problematic because it does cross the placenta and there's intracranial hemorrhage risk for the fetus. However, the embryopathy is quite low if you're on less than 5 milligrams. Unfractionated heparin doesn't cross, but has a terrible ability to dose because of its short variable response half-life. So it really needs to be a drip to be effective. And because of this, patients on this have increased risk of valve thrombosis. Low molecular weight heparin has a nice bioavailability and ease of administration, but it does not seem to be adequate for mechanical heart valves in pregnancy. And so to use this with a well-counseled patient, you need to be measuring 10A levels at the peak to assure that you're adequately anticoagulating. So if you're thinking this through, if you have a patient who has a mechanical valve, who needs anticoagulation and their baseline dose is less than 5 in the first trimester, you can either continue that or move to the adjusted low molecular weight heparin. If they're more than 5, then again, you want to move to that adjusted weight heparin for the embryopathy in the first trimester. Then in the second and third trimesters, switch back to warfarin with your goal plus add aspirin. And then before delivery, discontinue your warfarin and dose adjust continuously your unfractionated heparins until delivery to minimize maternal bleeding risk. I kind of like this because it's a visual way of helping patients think about risk as both mom and baby risk. So this gives your vitamin K agonists, your warfarin, your low molecular weight heparins, your unfractionated heparins, and it gives you both the risk to the mother and the risk to the fetus, but then it combines them so that you can see that risk is not just one or the other. You can't choose mommy risk and avoid baby risk. You've got to think about them together. And so when you take those things together, the lowest risk group, the lowest risk option is really low dose warfarin, lowers the risk of the combination of a maternal or fetal event. So in summary, cardiovascular disease is present in about 1 to 2% of all pregnancies. Congenital heart disease is the most common type in North America and is on the rise. Heart disease does not preclude pregnancy, but certainly warrants special counseling and evaluation. There is an increase to the mother and to the fetus in all types of heart disease, congenital and acquired, and depending on your patient's exact risk factors, disease findings, and ongoing therapies, the risk needs to be individualized. An individual assessment is necessary before pregnancy, ideally, but at least in early pregnancy. And for many of these patients, multidisciplinary care is critical to assuring a good outcome. I have a number of references, and I will be in the question session at the end of this section, and I look forward to speaking with you all then. Thank you so much again for inviting me, and have a great rest of your conference.
Thank you so much. We thank Professor Thunberg for sharing an experience on cardiac disease in pregnancy. 1 to 2% in pregnancy, not very common, but you do come across patients like this. In our environment, peripartum cardiomyopathy, I remember when we were training as a resident, peripartum cardiomyopathy was quite common, but I think a lot of that now you get in the north. So we'll just go on. I see in the audience, we have Dr. Sonia, Dr. Stringer, and Dr. Vaught. We thank them very much for joining. We have 3 more lectures, so I think we'll just go ahead. I hope that is okay. So the next session is by Professor Graves again. She's going to be talking about respiratory diseases in pregnancy. Professor Stringer.
Yes, I'm here. Sorry.
Okay, yeah. Sorry, there's concerning Professor Dr. Owen's lecture, there's a disconnect between the slides and the voice. I don't know if that's how it's meant to be. She actually spoke about something quite important, was preeclampsia, the burden of which is quite high here with us. I wasn't sure if that's how. Maybe you can find out from her if that's how it's meant. Maybe we'll sort that out while we take this next session.
Wait, can you repeat? Is there a problem with one of the lectures?
No, Dr. Owens, it's as if the slides are different, are separate from the picture, from the video.
Oh, okay. Let me see if I can talk to her.
Okay, so while we take this, thank you so much.
Okay, great.
Okay, so we'll go ahead with this.
Good afternoon, and thank you for the invitation to present at your Critical Care Obstetrical Conference. My name is Dr. Cornelia Graves. I am the Director of Perinatal Services for St. Thomas Health, the Medical Director for Tennessee Maternal Fetal Medicine, and a professor at the University of Tennessee. Today, we will be talking about respiratory failure in pregnancy. Before we get started, I would like you to know I have no financial disclosures. The objectives for this talk are as follows. We're going to discuss the physiologic changes of pregnancy that affect the respiratory system. We're going to identify the most common causes of respiratory distress in pregnancy. And in the end, we're going to talk about disease processes and implement a treatment plan. Well, respiratory insufficiency is one of the most common indications for admission to the critical care unit. It accounts for about 25% of all patients. Interestingly, this respiratory insufficiency complicates 0.1, 1 in 1,000 to 2 in 1,000 pregnancies. However, this incidence has been increasing as viral pneumonias have been taken center stage during the pandemic. Not only the COVID-19 pandemic, but also H1N1, SARS, and MERS, it all increase the risk of complications in respiratory complications in pregnancy. Well, let's look at physiologic changes. The first is at the beginning of pregnancy, women begin to hyperventilate. This begins in the first trimester and increases to about 48% at term. Now, no one is coming into your office going, what you're going to see is that this is really due to an increase in minute ventilation, which is stimulated by progesterone. For many of you who have worked in medicine, you know that for chronic obstructive pulmonary disease, in the past, progesterone has used to increase minute ventilation. The same as in pregnancy, it increases minute ventilation 20 to 40% above baseline. Other physiologic changes in pregnancy are that oxygen consumption is increased by about 20%. This is so that the fetus can have oxygen delivered effectively through the placenta. FEV1 remains unchanged. Tidal volume is increased, which is counterintuitive. Most people think, well, the baby is pressing up on the diaphragm. There are two ways tidal volume is increased. One is tidal volume is increased by expanding the AP diameter of the chest. And the second way tidal volume is increased is by minute ventilation. Functional residual capacity is decreased by 18%. This is the very first important point when looking at physiologic changes in pregnancy. When pregnant women do not tolerate respiratory insufficiency well. So a pregnant woman will be here, she will plateau slightly, and then she will fall off the cliff. This is due to the fact that she does not have respiratory reserve. Unlike other adult patients that often go here and plateau for a long period of time, the plateau period for a pregnant woman is shortened by this decrease in functional residual capacity. Pulmonary vascular resistance is decreased by 34% in order to deliver more blood to the pulmonary vasculature. And then call-out osmotic pressure is decreased by 14%. This increases the risk that the pulmonary capillaries will be leaky, increasing the chance for non-cardiogenic pulmonary edema, as we will discuss later in the lecture. Blood gases will reveal a compensatory respiratory alkalosis. This is compensated for by a renal acidosis, so your pH remains the same at approximately 7.4. However, resting arterial CO2 tension is decreased to about 30. Remember, we're hyperventilating. So therefore, a normal CO2 for adult CO2 in pregnancy is considered to be mild hypercapnia, as there's retention of CO2. In addition to that, Resting arterial O2 tension is about 105 millimeters per mercury, but due to the hyperventilation. And there's a shift to that O2 dissociation curve to the right to offload for the fetus. We see here in this particular diagram from up to date, this increase in minute volume that we just discussed. Oxygen uptake is also slightly increased by 20%, and there's a mild increase in basal metabolic rate. Here, as you can see, the changes in pulmonary function test. And what I really want us to look at is the functional residual capacity as denoted here. You will see that functional residual capacity begins to decrease throughout gestation, which means that patients do not tolerate respiratory insufficiency well. Well, what are the pulmonary diseases we need to be thinking about when we talk about respiratory distress? We'll address some of these at the end of the lecture. Asthma, pulmonary infections including pneumonia, pulmonary edema, systemic respiratory inflammatory response, or ARDS, pulmonary embolism, and air embolism. Also, there are non-pulmonary causes: drugs, myocardial infarction, or other cardiac issues, thoracic aortic dissection, acute chest syndrome, which is associated with sickle cell disease, and amniotic fluid embolism. If you noticed, I waited to the end to talk about anxiety. Anxiety should never be considered a part of respiratory distress until all other factors have been eliminated. Well, let's talk about respiratory failure. Respiratory failure is due to inadequate gas exchange. As we talked about, those pulmonic conditions such as pulmonary edema, acute respiratory distress syndrome, or pulmonary embolus, or extrapulmonary conditions such as the cardiac conditions that we spoke of. There are two types of respiratory failure. One, the patient is hypoxemic. Everybody recognizes that type of respiratory failure because the oxygen saturation is low. This is type 1 respiratory failure, and all of us we're like, oh yeah, the patient has respiratory failure. However, the second type of respiratory failure is hypercapnic respiratory failure. Hypercapnic respiratory failure is actually more difficult to diagnose because in pregnancy, as I said before, your CO2 is lower. So therefore, if a patient's PaCO2 is 40, they may be considered to be normal, although they're mildly hypercapnic, as I have pointed out. So when looking at blood gases, look at your O2 and your CO2 to make a diagnosis of respiratory failure. Well, when we talk about the mechanics of breathing, we need to think about this if we're going to be talking about respiratory diseases. Oxygen goes in, there's inhalation, and then the diaphragm expels, descends in order for the lungs to fill. The diaphragm then raises in exhalation. The space inside the chest actually decreases and CO2 is expelled. But in diseases such as asthma, CO2 may not be expelled. And so therefore, again, looking at that type 1 and type 2 respiratory failure, it is very important to make sure that you're evaluating both parts of the arterial blood gas. In addition to that, there's a physiology of gas exchange. Oxygen enters from the pulmonary artery. It is deoxygenated. The alveolar membrane then needs to have exchange of O2. O2 then diffuses into the red blood cells. Well, we know certain conditions such as pulmonary edema and ARDS or systemic inflammatory response will not allow oxygen to infuse into the cell as the basilar membrane has been damaged. In addition, as I talked about before, CO2 then needs to be diffused and into the pulmonary vein. So deoxygenated blood, oxygenated blood, and then a CO2 needs to be expelled before the cells can go back out into the pulmonary vein. Again, this can be hampered by disease processes, especially things that cause scarring of the alveoli, such as asthma and acute respiratory distress syndrome. Well, let's look at the oxygen pathway in pregnancy. So here's air and the maternal lung, O2 and CO2. So what are things that can keep air from getting in, such as drowning or inappropriate ventilator settings? We've already talked about things that affect the maternal lung. We also need to talk about circulation, heart failure, pulmonary embolism, a big one, anemia, and then aortic cable compression, which can hamper circulation, especially in pregnancy. Then, as we go down, we need to consider other things such as the uterus and hypotension, placenta due to infarcts, then kinks and occlusion of the umbilical artery, and then of course there is fetal circulation. So it's interrelated. So if the baby has fetal anemia or heart failure, you can see that the exchange of CO2 between the placenta, the mother, and the maternal respiratory system may be compromised. So, as I always like to use these little cartoons, this little pufferfish says, "I can't hold my breath much longer." So, how do we monitor respiratory failure? First, we need to examine the patient. We need to take our stethoscope and we need to decide if the patient's lungs sound like they have crackles or is she moving air at all? In the cardiac exam, is there a murmur? Is there other types of gallops we need to be taking a look at? Then we need to assess O2 saturation. Is it less than anything less than 95% in pregnancy is concerning? This is different from our adult colleagues in which 92% is felt to be satisfactory. Then we need to assess ventilation. Remember type 2 failure. Type 2 respiratory failure, that is hypercapnia, is something we need to keep in the back of our mind. And in pregnancy, we need to assess the respiratory rate, which for pregnant women is greater than or equal to 30. In the normal adult population, it would be greater or equal to 40. Then we need to ask ourselves some key clinical questions. Does your patient appear to be becoming unstable? What are your available resources? If you're in a low resource area, you may need to gather those resources or move the patient to a hospital with a higher resource area. So we don't want to wait till the last minute to take that opportunity to get the patient to the right place. Or if you live in any hospital I've ever worked in the United States, the hospital is just not very good at, we can say we're good, but we're not as good at 2 a.m. as we are at 2 p.m. So if it's getting late, we may need to think about that as well. Can the patient maintain her oxygenation on the current therapy? She on nasal cannula, rebreather? What do we have to help the patient maintain her oxygenation? What is the status of the fetus? Does the fetus look like it's not doing well? Is the patient contracting? Improving oxygenation can assist with that. Does the mother have a full stomach? We never want to wait to stabilize our patient in pregnancy, because most of the time women have a functional full stomach or are considered to be functional, which means that there's an increased risk for aspiration. So if we need to stabilize our mother, maybe we should consider obtaining our airway early, get our airway protection, so that we can then do what we need to do. We need to move the patient to the bigger hospital. That's something we need to think about. Are we going to intervene for the fetus? Yes or no? Well, if our hospital only does term babies, but the big hospital does preterm babies, maybe that's another reason to stabilize that mother and then move her. In addition to that, stabilization allows us to investigate the cause and treat the underlying cause of what is going on. Well, there are intermediate therapies that can provide short-term support for complications that may reverse very rapidly. First is masked oxygen. placing a mask and then usually 10 to 15 liters can often oxygenate our patient, keep those sats above 95 until we can take care of the situation, such as when we have fluid in the lungs. Then there's the non-rebreather mask, which we have to think about using because the non-rebreather mask also may help in some patients retain CO2. The CPAP mask is very helpful, especially in patients in which we need to worry about fluid in the lungs. And the beauty of CPAP mask is the CPAP mask actually does not require that we have to put intubate the patient. However, CPAP can be uncomfortable, and in patients who have a full stomach can increase the risk of aspiration. Last but not least is a laryngeal cuff. The laryngeal cuff, again, means that we do not have to put a tube down the patient's throat, but we can control her airway and possibly get her to a place in which we can stabilize her more efficiently. So what are the indications for mechanical ventilation? The first indication is the patient cannot maintain her oxygen saturation. She is hypoxic. That hypercapnia I keep on talking about, we can't blow off CO2. There's an increased work of breathing. Not only is she breathing 30 times a minute, but she's using the accessory muscles of her chest. Severe metabolic acidosis, for example, diabetic ketoacidosis, which we're going to talk about in a later lecture. A need for sedation. The patient needs to have a procedure such as a cesarean section. She is not a candidate for regional anesthesia. In patients who've had cardiac issues, to reduce oxygen demand so that the patient can heal. And anytime the patient has an altered mental status and her airway is unsecure, we need to consider mechanical ventilation. So the objectives of mechanical ventilation are not to keep the patient on the ventilator, but to allow her, the patient, to basically reverse her hypoxemia, hypercapnia, and take care of the acute respiratory acidosis, to relieve respiratory distress by allowing the patient to be sedated and to rest on the ventilator, to prevent and reverse the lung sticking together atelectasis, to make the lungs more compliant, and to prevent further injury. Really, the objective of mechanical ventilation is to facilitate lung and airway healing and to avoid complications. Well, what are the things to consider when you're deciding to intubate your patient? The first is the placement of the ET tube. Pregnant women have a smaller airway, and they're more likely to have edema. So they may need a smaller ET tube. Also, if you do not have a laryngoscope, you may just get someone who's experienced. You're more experienced and senior person to perform the intubation, as failure is 8 times more likely in pregnancy. There are several modes of ventilation, and I put them here just to remind everybody that you can do a pressure controlled, which is a bi-level ventilation, where the ventilation is based on pressure. One of the most common is the synchronized intermittent mandatory ventilatory support, or SIMV. And basically the patient and the ventilator work together in synchronization, but the ventilator is triggered by the patient's into inhalation. Then there's volume control, where we give the patient a volume. And then of course there's a high frequency oscillatory ventilation, which is very uncomfortable, mostly used in the neonatal intensive care unit and may not be available at your center. So let's make a breath. The ways we're going to make a breath is we're going to look at our inflation volume. We should tell our colleagues that we want about somewhere around 5 to 10 milligrams per kilogram. We want our peak inspiratory pressures to be greater than less than 35, 5 to 15 centimeters of PEEP. And we really want to keep our PCO2 around 27 to 34, except in viral pneumonias, in which we may need to consider allowing for more permissive hypercapnia. We do not have good data about permissive hypercapnia in pregnancy. Well, what about adjunct therapies? If you use betamethasone or dexamethasone, can be very helpful. We have found out in COVID-19 that dexamethasone is one of the best treatments for helping lungs overcome disease. Since we're going to be often give it, we need to think about this because we may need to give a dose that benefits both the mother and the fetus. It may be useful in acute respiratory distress syndrome, as we are seeing. After 14 days, though, so it needs to be instituted early because it may increase morbidity and mortality. Sedation is not contraindicated in pregnancy, but it may cause changes in your fetal heart rate, decrease variability, and decrease your baseline. So I tell people, when you put people on the ventilator, you decide you're going to deliver them or not going to deliver them. And if you're not going to deliver them, as long as you have a positive fetal heart rate and the baby's not having big decelerations, you don't need to worry about variability or baseline if the mother is sedated. And it's really important to sedate your patient, because what that's going to do is decrease your maternal oxygen consumption. I put this slide in here just because I just want to remind everyone about propofol. Propofol can cause vasodilatation and lead to decreased cardiac output. So avoid using it in high doses. Some of these drugs may not be familiar to you at your institution, but again, most of them are not contraindicated in pregnant women. The patient should be sedated if you're going to use a paralytic. Vecuronium and the other paralytics may cross the placenta, but they have very little effect on the fetus. And we know this because when we do other procedures, we have to actually inject the paralytic directly into the fetal cord. I just put the basics of ECMO here. I'm not, if your institution is thinking about looking at ECMO, it can be used in pregnant women. It is either VA or VV. ECMO in pregnancy, there were 18 patients, 4 were pregnant, median age 32 years, median gestational age 32 weeks. Maternal survival was 90%. Fetal survival was also 77%, and 100% fetus was viable. 4 patients were also delivered on ECMO. And the reason I talk about this is because often in pregnancy, there are therapies that we often think may not be useful, but these are, as you move your unit and do more advanced critical care procedures, keep in mind to include your pregnant population. Well, now we're going to talk about some common respiratory issues in pregnancy. Asthma, which is really the most common potentially serious medical complication of pregnancy, and we often don't talk about it. Nearly 6% of women are pregnant women are affected with asthma, and for some reason the morbidity appears to be increasing. Asthma can present in a number of ways: wheezing, cough after exercise, dyspnea, shortness of breath, chest tightness. Always keep in mind that just because people do not have asthma as a child does not mean they cannot have it as an adult. The reason that asthma makes it hard for people to breathe is because these inflamed bronchioles, while they may let oxygen in, do not let CO2 out. Eventually, they will not let oxygen or CO2 out, resulting in significant respiratory failure. Acute treatment for asthma is steroids, IV or oral. You can start with a dose somewhere between 40 and 60 milligrams 2 to 3 times a day. You want to remove their triggers. If they're allergic to dust, remove their dust. If they're allergic to cigarette smoke, remove the cigarette smoke. But anything that may trigger asthma needs to be removed. Aerosol treatments, either through the patient's personal inhaler or aerosols in the hospital, in your emergency room, oxygen, and then magnesium sulfate, 2 grams, helps to relax muscles. In status asthmaticus, which is rare, you need to look at both the fact that the patient is hypoxemic and hypercapnic. You want to do aggressive therapy, and in status asthmaticus, epinephrine is not contraindicated. If you're going to have to put the patient on a ventilator, you have to remember these patients make their own auto-PEEP. That's why you see them kind of pursing their lips. So you may overinflate the sac. Keep in mind, air doesn't get out well. So therefore, you need to be very careful to make sure that we do not injure the patient's lungs. But keep in mind, status asthmaticus can have a mortality as high as 7%. So in addition to the other therapies that we talked about, these patients, if they need it, can also have epinephrine as you would do in an anaphylactic reaction. Well, let's talk about pulmonary edema, which is one of the most common things we see. As we talked about in this lecture, it can be non-cardiogenic due to leaky pulmonary capillary bed, despite normal pressures, such as postpartum pulmonary edema in the face of preeclampsia. Pulmonary edema we often see with preeclampsia. And in patients who are having infections, often they have pulmonary edema, which is a systemic inflammatory response. ARDS is a form of non-cardiogenic pulmonary edema. And then there's cardiogenic pulmonary edema due to elevated intravascular pressures that create a gradient so that fluid moves into the lungs more due to fluid overload, despite the fact that the lung is normal. We see this often in preeclampsia, especially in patients in which the left heart, has decided not to work well. And we see it in volume overload as well. And sometimes we see it when we give magnesium or extra volume in pregnancy. Again, this is, you can see there's normal hydrostatic pressure, but increased permeability. That would be non-cardiogenic pulmonary edema. And then increased hydrostatic pressure, which leads to increased fluid filtration, which is cardiogenic pulmonary edema. So the way I like to look about this is called Mad Dog. You want to give them medications, morphine and antibiotics if you think they have infections. Establish an airway. We talked about mask. This is a great place for CPAP if you only need to use it for a short period of time. We want to decrease preload with antihypertensives if the patient's hypertensive. Give diuretics in order to diurese the patient, oxygen, and then in the end, we want to get arterial blood gases to make sure that this is pulmonary edema versus acute respiratory distress syndrome, which would we would be able to delineate by looking at oxygenation. Another thing that we see often is a VTE, pulmonary embolus, any type of venous thromboembolus. D-dimer may be used, the usefulness in pregnancy is controversial, although the New England Journal of Medicine had a very good article that showed that values over 1,000 may be diagnostic, but D-dimers also are elevated in preterm labor, preeclampsia, and abruption. And keep in mind, if you use a CT or a VQ scan, that you can miss these segmental lesions and peripheral lesions. A VQ scan may be the first step, especially at your institution. The sensitivity ranges between 27 to 95%, given the fact that these segmental lesions can become a problem. You can also look at the patients using compression ultrasound, especially for proximal DVTs. The sensitivity is 97% with a specificity of 94%. It's less accurate for isolated cath DVT, and it is not adequate for the diagnosis of the iliac vein thrombosis, for which requires usually a CT scan. Again, the treatment is IV heparin or low molecular weight heparin, and we can talk about how to approach this with the doses of medications that you use in the discussion session. And then look for causes such as injury. Did the patient hit her leg? Pregnancy, of course, hypercoagulability. Thrombophilia, we need to be aware that certain clotting factors, especially prothrombin, factor V, may increase our risk. And then cardiac, is the patient's heart functioning normal, or is the clot coming either from a hole in the heart, or is the clot coming from the fact that the heart cannot beat appropriately, and so therefore is forming thrombosis? So in conclusion, respiratory failure complicates 1 in 500 pregnancies. Understanding pregnancy physiology is important to recognizing this failure, and then identifying the underlying cause may dictate a treatment plan. I thank you for your attention. Here are selected references, and I look forward to your questions, the question and answer session.
Thank you so much. We thank Professor Graves for sharing our experience, respiratory diseases in pregnancy. We have a different spectrum of diseases, but nonetheless, it's important, especially in these days of COVID-19, that keep coming up and the various variants. The next lecture we're going to be listening to is on hypertensive diseases in pregnancy. Quite important again in this environment because we have a huge burden. Professor Owen will be doing that. Can she share her screen now? Let me see. Yeah, okay, she started sharing. Okay, I'll put on the sound now. Okay. Oh boy. Just a minute. Oh boy. Oh God. No, 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 no. We can hear that. Professor Stringer.
I'm here. Yes, Dr. Adesina.
Can you hear the audio?
I cannot hear the audio.
Okay, what about now?
I cannot.
Okay, just a minute. Let me just
I just wanted to share them with you today. So let's get started with our objectives. At the end of this lecture, it's hoped that you'll be able to understand the complications of poorly managed hypertensive disorders in pregnancy, that you will be able to identify.
I cannot hear anything. Can you hear it on your side?
I can.
I can hear it.
You can?
Yes, we heard it. I heard it.
Oh, okay. Okay, more people can share simultaneously. Okay, yeah. Okay.
Risk for complications of hypertensive disease.
So let me start again. Okay.
Good morning. I am Dr. Michelle Owens. I am professor and chief of the Division of Maternal Fetal Medicine at the University.
Maybe turn up the volume too.
And a member of the Society for Maternal Fetal Medicine. I have the honor of.
Ooh. Oh boy, just a minute. Let me do that again.
But I could hear her.
Oh, so you could hear the recording?
Yes, I could hear her, but I couldn't see the screen. There's nothing on the screen.
Okay, let's do that again. I can see this is Professor Owen's screen. So let's just do that again. Just a minute. Okay. Oh, wow.
Pregnancy, preeclampsia and the preeclampsia spectrum. I've entitled this talk, What's New Again? Because as you will see, there have been some things that have kind of resurfaced as we have grown in our knowledge and understanding of this potentially deadly disease.
So another solution,
I have
would be to go right into Dr. Vaught's slides, and then we can just send out these with audio. We'll send it out with the audio. So if people want to, on their own,
then they can listen to it. Okay.
Does that sound okay? Sorry about that, but we'll make sure everyone gets it.
Yes. Okay. I think we'll just do that. So let me go to Dr. Vaught's presentation. Just a minute. Sepsis. Yeah.
Hello, my name is Jason Vaught. I am a maternal-fetal medicine specialist. And surgical critical care physician at the Johns Hopkins Hospital and University. And today I will be talking to you about sepsis and pregnancy, recognition, diagnosis, and management, and pretty much going over the surviving sepsis guidelines. So let's start off with the patient vignette. The patient is something that is pretty familiar to many of us that cover L&D or that do consultations there. But the patient is a 33-year-old G1P0 at 40 weeks and 1 day, admitted for induction of labor at term. At the beginning of her induction, her cervix is 0, 0, -4, or pretty much closed, so she is given Foley bulb and misoprostol. She proceeds to 4 centimeters dilated and then has her membranes ruptured. After her rupture of membrane, she has a prolonged labor course. And she also has decreasing urine output in abnormal labs, indicative of a serum creatinine of 1.3 milligrams per deciliter. At that point, a cesarean section is called for prolonged induction of labor or failed induction of labor and abnormal lab abnormalities. Her cesarean section is uncomplicated, but postoperatively, you're called to the PACU for agitation and anxiety. These are her vitals. At 11 a.m., as you can see, she has a temperature of 39.4, and then that which is reconfirmed at 39.1, and deprivesces after Tylenol. You can also see that she's very tachycardic to 153 beats per minute, and then with fluid bolus comes down to 122. Interestingly enough, she has a blood pressure of 187 over 125, which I think can confuse many people on L&D as of what's going on and broaden the differential diagnosis. Stat labs are sent from the PACU area, and you can notice that there is a lactate of 5.3, a white blood cell count of 2.68, a hemoglobin of 11.9, new onset thrombocytopenia at 91,000, and a vandemia of 45, and her creatinine has worsened to 1.7. So what's your differential diagnosis?
No, ma'am. Is that?
So of course, here are your differential diagnoses. One is bleeding, right? Is the patient in hemorrhagic shock? The patient is acutely from the operating room from a cesarean section. And again, when someone's in PACU and they're hypotensive tachycardic, it's bleeding until proven otherwise. Pulmonary embolism, certainly on the differential, which would be with tachycardia, looking for hypoxemia. Again, someone who's had a prolonged induction of labor, pregnant, could have had a DVT throughout her induction, which propagated after surgery. Then, of course, there is sepsis. The discussion is about sepsis. So, of course, that is on our differential diagnosis for this vignette. And, the patient is febrile, has a bandemia, has a low white blood cell count, which we will find is also indicative of sepsis. And then less common amniotic fluid embolisms, which certainly should be on the differential, but again, something that's less common than the three that we have listed above, malignant hyperthermia, particularly if the patient has a family history of malignant hyperthermia, or if the patient had general anesthesia. And then, of course, one which should truly be a diagnosis of exclusion. And I can't stress that enough, that these should be diagnoses of exclusion after you looked at every other possible reason for this patient's decompensation. And agitation is psychosomatic disorders such as acute anxiety. And so again, like, these are differential diagnoses. It is certainly not limited to these. I just wanted to think of some that would get our mind jogging and going if we approached a patient like this in our PACUs. So let's talk about the incidence of sepsis. Sepsis is the leading cause of death of the critically ill in the US. It's the third leading cause of maternal deaths in the US and accounts for 5% of all ICU admissions. So why is this topic so important? Why should we be really talking about sepsis, especially when cardiovascular conditions and mortality are on the rise in pregnancy? But also, we know that when we discuss these topics that there can be decreases, right? So we've had a decrease in hemorrhage with hemorrhage bundles, and also a decrease in mortality with hypertensive disorders of pregnancy with hypertensive bundles. However, when we look at infection and sepsis, there really hasn't been any change or trend towards any improvement over the past few decades. So why has there been no improvement? One, we continue to have knowledge gaps in the current definition, recommendations, and guidelines. So a favorite quote that I hear on LND is, "She's not septic because her blood cultures are negative." Another is that we have an inability to identify patients with disease. So you don't think she's septic, do you? And then also, when disease is identified, failure to recognize severity or critical illness is still present. So one of the quotes that I hear is, "She's septic, but she is not septic. And she's only a little septic." So how do we define sepsis in 2021? Heart rate and tachycardia, respiratory rate and tachypnea, and a high or low white blood cell count. In 2004, the Society of Critical Care Medicine published the Surviving Sepsis campaign. And they used the definition that Robert Bone taken from SIRS and had made a grading system of severity, going from SIRS to sepsis, sepsis to severe sepsis, and sepsis to septic shock. In 2016, the Society of Critical Care Medicine came out with the Sepsis 3 campaign, which basically stated that sepsis was neither mild nor severe. It pretty much stated that sepsis within itself was life-threatening and could progress, and there needed to be pretty much increase in care and monitoring to ensure that the patient can, one, it's not a great screening. There's a lot of focus on inflammation. It doesn't actually
this that goes inside. That one, if you are coming from my side, you have to wait. Waiting.
I apologize that the audio is not working now.
Hi, this is Jason Vaught. Do you need me to give the talk live? Would that work?
Yes, if you can do that, I think we just go with that. Is that okay? Is that okay with everyone if Dr. Vaught just goes ahead and gives the talk without, so you can, since you're there?
Yeah, I think it's okay.
Okay. I think that would be great. Thanks, Jason.
Okay, does that mean he's going to share his screen?
Dr. Vaught, do you want to just get them to advance the, how would we do that? Can you?
Let me see, I can, instead of doing this, then, oh boy. Let me just share this again. So I'll just move the slides, but it won't be on on slideshow.
Okay.
Okay, Dr. Vaught, can you do that? Does that work?
Yeah, that works for me. What slide do you want to go back to?
I think we need to go back like 5 slides, I think.
Okay, 5 slides.
Okay, that's fine. Let's do it. Let's go back 5 slides. We can totally do that.
1, 2, 3, 4, 5.
Okay,
this is okay?
Yeah, no, it's totally fine. I want to share my computer screen.
Oh, do you want to share your screen?
Oh no, or I mean, like if it's easier for you guys, I can just say next slide.
Yeah. Let's go on. Let's go on like this.
Okay. Let me know when you're ready for me to begin.
Yeah, you can go ahead and just tell me when you want me to move the slides.
Okay. So, thank you guys for kind of hanging with us through this. Again, we're talking about how do we define sepsis in 2021. So as you can see, in 1992, there was the SIRS criteria created by Robert Boone and the Chest Society, which we all know includes heart rate, temperature, respiratory rate, and white blood cell count or bandemia. Then in 2004, there was this notion of SIRS going into septic shock and more of a leveled case of SIRS, sepsis, severe sepsis, and septic shock. And then we kind of got rid of that because we felt that sepsis was more of a spectrum of disease. And we came to 2016 with the Sepsis 3 guidelines at the 45th Annual Society of Critical Care Conference. And this was published in JAMA. Next slide. So why did we get rid of SIRS? So it's not really a great screening tool. There's a lot of focus on inflammation. And it does not reflect on actually who goes to the ICU, right? We don't necessarily send patients to the intensive care unit for white counts or for the fact that they're febrile. We may send them to the ICU. We may send them to the hospital for those reasons, but that's not why they go to intensive care units. Patients go to the ICU for hypotension, acute kidney injury, mental status changes, et cetera. Also, too, patients with a common cold or pancreatitis can be diagnosed with sepsis, which we know is also not true. Next slide. So when we look, when we look at defining sepsis in 2021, we actually look at the QSOFA, which stands for Quick Sequential Organ Failure Assessment Score. And this is based off of the SOFA score, which looks at a tiered level of organ dysfunction through altered mental status, through GCS profile, or Glasgow coma screening profile, acute kidney injury by serum creatinine, thrombophilia through platelet disorders, and also to respiratory failure, looking at pulmonary to FiO2 ratios. And we found that if you have 2 of the 3 clinical variables of a respiratory rate greater than 22, an altered mental status, or systolic blood pressure of less than 100, it was similar to that of mortality or predictability of that of a SOFA score of 10%. Next slide. So obviously the QSOFA score has not necessarily been validated for pregnancy. So other societies have opted for using like a QSOFA maternal score. And they changed the parameters for systolic blood pressure of less than 90, because many of our patients will have blood pressures with systolics from 90 to 100, a respiratory rate of greater than 25, and altered mental status remains the same. And the SOFA score, a serum creatinine of greater than 1.2 is considered abnormal. However, in pregnancy, we know that anything greater than 1.0 can be abnormal. So SOMANS actually changed the abnormal serum creatinine level from 1.2 to 1.02. Next slide. Although sepsis is clinically primarily diagnosed through clinic diagnostic tools, there are other tools or other adjuncts to this. One is the procalcitonin. So procalcitonin is a level that's used quite often in the US and across Europe. And in healthy individuals, calcitonin is produced by the Cal1 gene, and the levels are very low, less than 0.1 nanograms per ml. However, in sepsis, it bypasses this product this way, and it's produced by the lipopolysaccharides and toxic metabolites of microbes. And as you can see, it actually becomes a higher circulation, and usually the levels peak within 6 hours. Next slide. So, using procalcitonin as a diagnostic tool, elevated levels have shown to be helpful in diagnosing bacterial infections, especially pulmonary. So a level greater than 0.2 is kind of indicative of a bacterial infection. A level of greater than 2.0 can be associated with higher mortality. And in an observational study, they found that levels are unchanged in pregnancy. Although, you shouldn't just use procalcitonins on diagnostics alone, it can aid in diagnostics of sepsis, as well as looking at sepsis versus inflammation in immunocompromised hosts or high inflammatory states. Next slide. This is a a flow chart that looks at the use of procalcitonin in local infections, sepsis, and septic shock. And as you can see, as the procalcitonin levels become higher, they actually do have, as the procalcitonin levels become higher, there is a higher morbidity and mortality associated with septic shock. I actually can't see my slide right now.
Something happened to the slides. Dr. Adesina?
I think she's logged out. So we'll have to
Give
get
me a minute. I think my network, I'll be back in a minute now. Just a minute, please.
Oh, no problem.
Okay. Okay, just a minute, please. Okay. We're back.
Sure.
Okay, and I think we're somewhere.
Yeah, if you keep going down, you will see.
I think we're somewhere here.
Go to slide 15.
15,
Yep.
yeah, this is slide 15.
Yeah, so let's go back to our patient vignette, right? So whatever.
on slide 14.
Yeah, so whatever modality that you use to diagnose sepsis, whether it's SIRS or, oh no, we finished slide 14. Whether it's SIRS, QSOFA, the SOFA score, or any other modality, this is someone that has sepsis. And the source is likely an endomyometritis. So the question is now what? So next question, or next slide. Go to slide 17. That one was actually deleted from the top. Yep, perfect. So really, this is where your surviving sepsis campaign bundles come in. And this was from 2013 from Society of Critical Care Medicine. And they found, and they kind of slated things that should be done within 3 hours and within 6 hours. So within 3 hours, these are things that most of us can do, like, right, so measure a lactate level. One can get blood cultures, start broad spectrum or antibiotics that are available to them, and administer crystalloid fluids at 30 cc's per kilogram in the setting of shock. To be completed within 6 hours is apply vasopressors if necessary, and in the event of arterial hypotension and volume resuscitation, remeasuring a lactate, measuring a central venous pressure, and resuscitating according to those measures. Next slide. So when it comes to cultures, ideally, we would like to collect 2 sets of blood cultures, and you would not hold antibiotics to collect cultures alone. If you start antibiotics before collecting cultures, they can still be valid, but you just have to recognize that there can be sterilization within the first few hours of the first dose of antibiotics. And cultures are helpful because it actually can help you de-escalate antibiotics and know if your treatment is effective. Next slide. For antimicrobials, the goal is to really try to administer the antibiotics within the first hour. When you're giving a patient antibiotics, you can take in things such as antibiotic exposure history and previous hospital admission, past medical history such as autoimmune disorders and transplant, colonizations. For instance, if someone has cystic fibrosis, mostly those patients are colonized with Pseudomonas. So if they have a pulmonary infection, starting an anti-pseudomonal agent would be appropriate. If they have implanted devices such as a PICC line or any type of catheter for long-term like antibiotics or chemotherapy, and then also to job, travel, and other extracurricular activity that they may be doing. Next slide. When it comes to antimicrobials in septic shock, it's better to go big and broad. So be thinking about resistant gram-positive, such as in the use of vancomycin, daptomycin, linezolid. Be thinking about gram-negative, so starting piptazo, carbapentamases. If they are immunocompromised, you can be thinking of CMV infections. And then, of course, for immunocompromised or HIV/AIDS or cancer, they can certainly have invasive fungal infections. Next slide. Some hallmarks of antimicrobial use in septic shock. The dosage matters. So remember that in pregnancy, we already have this increased volume of distribution. Also too, in sepsis, there's a decrease in oncotic pressure and increased compartmentalization. So these two things compounded can keep you underdosed. And so maybe not as effective in the setting of septic shock with antimicrobials. So making sure that you discuss with pharmacy or with any antibiotic stewardship or ID can be very helpful. Also remember there's increased kidney activity with increased GFR, increased hepatic activity and metabolism with increase in the CYP3A4 and CYP3A5. And below I just have a list of medications that are frequently underdosed in sepsis and in pregnancy. So vancomycin, aminoglycosides, carbapentamases, and penicillins. So again, remembering that like not only do they have this increased volume of distribution because of their sepsis, but also because of their pregnancy. Next slide. With resuscitation, the goal is to either clear the lactate, which has been measured, or clear the acidosis if you're measuring base deficit. So really you want to see those gaps kind of come to a close, and you do that with IV fluids. Per SCCM, the MAP goal is 65 millimeters of mercury. However, there are some that advocate for MAPs of 60 in pregnancy since there is some lower blood pressure associated with pregnancy. Crystalloids are the initial choice, so normal saline, lactated ringers, and plasmolite. And you should be doing 30 cc's per kilo within 3 hours. If large volumes of crystalloids are used, it is very reasonable to adjunct resuscitation with albumin, 5 or 25%. Next slide. When it comes to resuscitation, there is this kind of notion of a balanced resuscitation versus an unbalanced. So balanced resuscitation is more kind of using plasmolite or lactated ringer, something that has more that has more basic solution in it. And normal saline is more unbalanced, so a higher sodium content, a higher chloride content, and a higher risk of actually going into acidosis. But in all, you can click next. It matters and like what exactly is available to you. So if you only have normal saline available at your hospital, it's very reasonable to use that for your initial choice of resuscitation. If you only have lactated ringers, that's also very reasonable. Next slide. When we're resuscitating septic patients, particularly pregnant septic patients, we have to remember that there is, again, that loss of oncotic pressure in sepsis and septic shock. So these patients are like at increased risk of capillary leak, vasodilation, and fluid overload. So remembering that, like, checking their lungs, checking for pulmonary edema, checking their extremities, looking to see if they're becoming more edematous is so important. So again, keeping that in mind with resuscitation is so important. Next slide. If you have someone who is refractory to the initial fluid resuscitation of 30 cc's per kilo, your next step is actually to add norepinephrine or a vasoconstrictor or a vasopressor. And so norepinephrine is safe to use in pregnancy, and you would not use another vasopressor unless you did not have norepinephrine available to you. You just have to remember that the risk factors for norepinephrine include tachyarrhythmias, so they can go into atrial fibrillation, sometimes even reflex bradycardias at very high doses. If the patient is under resuscitated or has not received enough fluid, they can actually have an increase in lactic acidosis. And also too, if you notice this, it means that maybe you should have a reassessment. Does the patient also have concomitant heart failure? Do you have source control, things of that nature? Next slide. Also to always remember to remeasure a lactate at the end of your resuscitation. So if your lactate starts off at 5 and it comes down to 2, then you know you're doing the right thing. If it starts off at 4 and you're now at 6.1, maybe we're missing something. Next slide. And then of course there are adjuncts to resuscitation. So for patients that we may think have relative adrenal insufficiency, that have been on long-term corticosteroids greater than 10 milligrams, have a history of adrenal insufficiency, or maybe have also had a hemorrhage and have Sheehan syndrome, starting hydrocortisone is very reasonable. There's also been some studies that have looked at supplemental vasopressin and also, of course, red cell transfusion to increase the oxygen carrying capacity. Next slide. So back to our patient vignette. She received 3 liters of fluid. She got blood cultures. She was started on Amgen and Clenda, and she rapidly improved in the next 12 hours. She did not have an ICU admission, but we did cardiac monitoring and arterial invasive monitoring in our L&D because we have the capabilities to do that. The gram-negative bacteria that grew back was actually ESBL E. coli, which thankfully was sensitive to the gentamicin that is in our Pyxis. And the reason I wanted to show this is because, you know, this is someone who we would have thought would have had, if she had E. coli, would have been a very pan-sensitive E. coli. But again, in the essence of septic shock and lactic acidosis, sometimes it's better to go broader because you don't know exactly what the patient is sick from. Next slide. And then also, of course, remember source control is such an important aspect of surgical sepsis. So there's procedural source control versus surgical source control. Procedural source control would be like placing an IR guided drain or aspirating an abscess through ultrasound. Surgical source control, especially in pregnancy and with endomyometritis, would be like a hysterectomy. And sometimes that actually is necessary. When it comes to stopping antibiotics after attaining source control, you should consider blood culture data, resistance data, and the global critical illness of the patient. However, a study came out of New England Journal of Medicine in 2015, which showed that you could stop antibiotics after 4 days of getting source control in large infections or in septic shock. Next slide. And with that, I thank you for your time and your patience, and I hope you have a wonderful rest of your conference. Thank you.
Thank you so much, Dr. Vaught. And I want to thank everybody who has kept on with us since we started about over 4 hours ago, actually. It's been a very, very educative session. Now what I see is patients are similar, even though the resources available to us may be a bit different, but I just see it as an opportunity to see how else we can improve. And I always believe that there's so much that we can do. If we have questions, I think we can take a few questions. We can indicate by show of hands. I can see Dr. Gafar Jimo.
Yes, Dr. Jimo.
Okay. Okay. Dr. Oshinaike, please go ahead. Dr. Oshinaike is, I think, associate professor in anesthesia. Dr. Oshinaike, can you go ahead, please?
Thank you very much, Dr. Adishino. My question is to the last speaker. In a setting of, you have sepsis in a patient who is pregnant. We know that they have increased circulating blood volume. Do you think it's still wise to go out with 30 ml per kg in this patient, low oncotic pressure?
What? I'm sorry. You asked, is it wise what? Could you repeat the question?
Yeah, I'm saying, do you think it's wise, it's okay to go out with 30 ml per kg initial bolus in this patient who is pregnant with sepsis?
So that's an excellent question. And so there are some that, and I kind of agree with this, because they already have an increased circulating blood volume of up to 50 to 60%. There are some that say maybe don't do 30 cc's per kg, maybe 20 cc's per kg or 15 cc's per kg. And we do have to, and that you bring up an excellent point that like our patient population, they are at increased risk of pulmonary edema and for these changes. So yes, there is kind of a breakaway from that where Society of Critical Care Medicine actually lowers from 30 cc's per kg to 20 cc's per kg.
Okay, thank you.
Thank you.
Can I just add another one?
Yes, please go ahead, Dr. Shinaiki.
There is a comment. The Surviving Sepsis campaign, they have a recommendation for 1 hour bundle. What do you think about that? How easy is it to implement 1 hour bundle even in US? I know it's quite difficult to do that. Even in 3 hours or 6 hours is very difficult in Africa. So
Sure.
the 1 hour bundle, how easy is it to implement that in US?
So also an excellent question, and the feasibility to implement that bundle depends on probably the unit that you're in. So for example, on labor and delivery, it is pretty easy for us to implement that bundle for Amgen and Clinton because those medications are in our Pyxis. However, let's say that we want to get meropenem from the pharmacy. That will take much longer. However, if we're in the ICU, in the intensive care unit, meropenem is in the Pyxis, so it's easy to implement it. So it is very location-based. I also want to add that that hour is like a goal. but you can only do so much and you can only do the best that you can. I think that each institution, nation, unit has to have their own standard for what they think is appropriate for their patient population. So if you tell me like, 3 hours is what we can do, then 3 hours is what you can do.
And then I would just like to add, Dr. Vaught, that is one of the things that hospitals are measured on, right? Like how it's a quality measure. And so we're always striving to get better, but we kind of know how we're doing.
Right. It's certainly a metric, and again, I want to add that there are certain medications that are on the L&D Pyxis that are not in our Pyxis. So if someone on L&D at Hopkins needs Zosyn, it's going to take a little bit longer than it would if they just needed ampicillin, because ampicillin we actually have in our medication Pyxis. But Dr. Stringer is correct. It is a measure. It's a measure that hospitals in the US that we're graded on. And so we have to keep that data.
Thank you.
Thank you. That was an excellent question.
Okay, so thank you so much, Dr. Shinaki. Thank you, Dr. Vaught, and thank you, Dr. Stringer. So if there are other questions, we can indicate. There were some questions that people put in before. There was somebody made a comment about adherent placenta, including placenta previa, not being common in Nigeria, and that the woman trial had actually showed a low prevalence of that. Well, I'm not sure the prevalence is high. It's just that one case that you see can be quite, can be a challenge if you've not prepared for it. And I believe that's the essence of having simulations, or sometimes, how do we put it now? You go through the session and try to prepare, because that one case that you do get can be quite challenging, especially in an environment where blood products are not readily available. I believe there was a case, a presentation, and somebody mentioned that patient got 90 units of blood or so. I can't remember who made that presentation just now. So blood is not something that is so readily available in our environment. And if you can prepare for the patient definitely will be the better for it. And then somebody also asked the question, the relationship between diet and cardiovascular disease. I think that question is probably directed towards Professor Graves. I don't know if she's still around. So maybe she can take that. Is Professor Graves still with us? Oh, okay, yeah, she was here all day. Okay, well, I think, so diet, of course, has so many, relationship with cardiovascular disease, of course, the long-term, if obesity and all that, even having undernutrition. But one thing that came to my mind on seeing this question was the relationship between, I think, potash, the use of potash and peripartum cardiomyopathy. In some communities, the use of potash has been associated with peripartum cardiomyopathy, although I think that probably requires more study. I know some people have done some studies, but of course, it will need to, we'll continue to do more studies on that. So on that note, I think we can bring the day to a halt. Professor Stringer, a last comment from you.
I would just like to thank you for your for organizing everything. I think this has been a wonderful experience for all of the presenters, and I hope it was for the participants as well. And thank you so much. And we'll be sure to get Dr. Owen's lecture to everyone. And then if there are other questions in the future, we'll kind of problem solve on how to get those answered. Thank you so much.
Thank you so much. And thank you so much for accepting our invitation. I think you've added a lot of color and flavor to the conference. We thank you, we appreciate you. Well, maybe let me just also let people know the Society for Maternal-Fetal Medicine. If you just go onto their website, they're open to people joining. And since I've joined, I think I have, they have a lot of resources. I think it's something definitely worth, I think it's a body definitely worth joining. And this is one of the benefits.
I would like to add that it is free registration for anyone from a lower income country, and you can access lectures. And so I would encourage you, if you're interested in high risk obstetrics, to join.
Yes. Yes, I think it's been a wonderful experience for me anyway since joining. So I would recommend everybody joining. I'd also recommend joining AFEMSON. I think this collaboration we can continue to keep. We can take places and more trainings in the future. So thank you so much, everybody. We also thank our audience who have been here. We're at a point we had, I think, about 220 people join, and those people who have continued to stay, I can say about half of them, at least 50%, who are continuing to stay. Thank you so much for staying here. So tomorrow the conference continues. We have the abstract sessions, scientific sessions, the opening ceremony, and then more scientific sessions. So anybody who wants to join, please feel free. We'll try and make, what we're working on is making these presentations on the website for some time, so that we can still access them for quite well. So if you go to the AFEMSON website, you'll be able to see a link and what we intend to do with them, so people can still watch. I think they've been quite educative, and I think
thank
it's
you
something
so
that we
much.
can all listen to. Thank you so much, everybody.
Good night.
Thank you, Dr. Stringard. Thank you, Dr. Sonia. Let me see who else is around. Okay. Ooh, this has been a long. Oh, Professor Karen Fox, thank you for joining. It's been great to have you.
Hi, I'm so sorry for the delay. I am between clinic and running off to an accretus surgery.
No problem. Thank you so much. We enjoyed your lecture. Very, very educative. And we hope that we, at a later date, we can have you come around again to talk to people. Thank you so much for
Would love
sharing.
it. And please, thank you. I was going to say, please encourage people to send questions via email if I'm unable to answer them live, simply again, because I'm running off to actually do an accretic case.
No problem. Yes, thank you. Okay. Okay, Professor Tombag, I see you're still here as well.
Yes, I'm still here.
Thank you so much for joining. It's been a wonderful evening.
Thank you so much for having us.
It was a real pleasure. Thank you so much. Okay. Let me see. Yeah. Ooh. Wow. It's been a long day.
Thank you, everyone.
Thank you. Thank you, everybody. Have a lovely night.
Thank you, Ma. Well done.
Thank you.
Thank you.
Thank you so much.
Thank you. Good night.
Thank you so much. Good night. See you tomorrow.
See you tomorrow. Thank you, everyone.
Bye.
Bye.
you. Bye.
Thanks. Make the date.
Dr. Additional, well done.
Oh, God,
It's been a long day.
Oh boy, tell me about it.
It's been what? It's been what it's.
Yes.
Yeah, definitely. Definitely. Well done, man. Had to go.
Recorded this. Okay, we recorded it.
Just me. Okay.
Oh God, yeah.